I'm Dr. Ashish Phadnis, the Secretary of the Bombay Orthopedic Society. Today, we are having an interesting session on spine, and this is going to be in association with the British Association of Spine Surgeons. And I welcome you all for this. Before I hand over the proceedings to the spine surgeons, a brief about what Bombay Orthopedic Society is. This year, we'll be celebrating our 6 decades of excellence of the Bombay Orthopedic Society since its inception. The Bombay Orthopedic Society has sort of contributed immensely to Indian orthopedics, to academics in our country, training multiple orthopedic surgeons, and so much so that most of the people look forward to the academic programs of the Bombay Orthopedic Society as a sort of an inspiration, and they look forward to attending them and sort of gaining knowledge and gaining from them. It all began with Dr. Katrak, who was the first orthopedic surgeon, and he had established the first orthopedic unit in India at the Wadia Children's Hospital in 1936. He established the first teaching unit at the Department of Orthopedics at KEM Hospital in Mumbai, and he was the first Indian to be awarded the honorary fellow of the British Orthopedic Association. During the founding years in 1965, a group of orthopedic surgeons, including Dr. Katrak, Dr. Ellen Vora, who was the first secretary, Dr. Masalawala, Dr. P.K. Mullah Firoz, were the two EC members. They all came together and formed the Bombay Orthopedic Society for pursuing and promoting academic excellence in orthopedics and for collaboration. This was the first exclusive orthopedic association in India. The eminent orthopedicians like Dr. Talwalkar, Dr. Dholakia, Dr. Kenny, and Dr. Masalawala played a key role in establishing the Bombay Orthopedic Society. Through the years, they had bi-monthly clinical meetings, and there was a lecturer program which ran over 3 days, and it was conducted every 6 months. And gradually, they conducted the annual conference, which was the VIROC. The first VIROC was held in 1966 at the Taj Palace Hotel in Mumbai. And since then, VIROC has been sort of the premier orthopedic meetings for the orthopedic surgeons across the country to attend. We had J&J traveling fellows from the orthopedic section of the ASI who would sort of participate. Then the Bombay Orthopedic Society had clinical meetings in the master series on a monthly basis. And over the period of time, these courses in trauma, spine, arthroplasty, arthroscopy, and the various subspecialties of orthopedics took sort of precedence. They became very popular, and now they are a regular feature on the academic calendar of orthopedics in the country. The BOS runs an active postgraduate teaching program where postgraduates from Mumbai and around the area, they sort of attend regularly, and it helps them sort of prepare for their exam. We have restarted conducting Bombay Orthopedic Society fellowships in various subspecialties and also facilitate observerships for interested orthopedic surgeons. VIROC, which is our premier academic event, is attended by surgeons from across the country and even from the neighboring countries. This year, we are proud to announce that we have a clinical journal, the Journal of Clinical Orthopedics, which is now indexed in the directory of open access journals, and it is a sort of 6 monthly publication, but we hope to attract more publications and hope to come up with more issues. The BOS started something innovative, which was the Protocols app, which is basically an orthopedic consenting app. And it features a lot of commonly performed orthopedic surgeries where the member or the surgeon can log in, and he can have a personalized consent which he can print out. And it is a very comprehensive app covering a lot of orthopedic procedures, and it is only evolving with the usage. The BOS supports research in various aspects, and a lot of its research has, some of its research has been published and has been acknowledged and has changed the practice in the city and across the country. So overall, we are a sort of very academic powerhouse, and directly or indirectly have influenced a lot of surgeons across the country. Our legacy is strong, but the future is even stronger. So this 60th year, there were a new sort of initiatives that we have undertaken. So we have worldwide webinars, one of which we are participating in right now. They have some outreach programs where members from the Bombay Orthopedic Society go to different cities across the country. They sort of participate in CMEs with the partnering association. And of course, we have some live surgery symposium. This year, monographs on various orthopedic topics will be released, and that will be available for the surgeons to refer to during the VIROC. And we have also sort of reignited the fellowship program. Um, yeah, the webinars we have conducted so far are some of them were with the Bone and Joint Journal on chondrosarcoma, with the Canadian Pediatric Orthopedic Society, with the Asia Pacific Orthopedic Association, the foot and ankle section. One of them was with the World Association of Infection in Orthopedics and Traumatology, with Dr. Agashe as a chief, and the Singapore Society of Hand Surgeons, who did one on the PIP joints and wrist fractures. The next one will be with SICOT, and this will be on arthroplasty. The current one will be going on with the British Association of Spine Surgeons. Outreach program, we have been to various cities: Vapi, Nanded, Chhattisgarh, Raipur, and the next one we'll be going to is Rajkot, covering various aspects of orthopedics, upper limb trauma, or whatever the different issues and the topics the local orthopedic associations have requested us to sort of conduct a CME on. There are various postgraduate education initiatives and programs being conducted with these programs as well. We have relive symposia. 4 of them are conducted this year. 2 of them, one on hand was conducted in May. The next one on foot and ankle will be conducted tomorrow. And these feature 17 to 18 surgeries, which are sort of recorded and which are presented by key opinion leaders. And these are watched by surgeons across the country at 17, 18 different cities. And there is a live interactive discussion happening either ways. I'll take this opportunity to invite the members of the BAS and all the members who are watching this webinar for our annual academic extravaganza, which is the VIROC. And this will be on the 26th to the 28th of December. And this will be at Westin. And my sort of organizing chairman, Dr. Gautam Zaveri, unfortunately couldn't be here. And the organizing secretaries, Dr. Paraglad and Dr. Chasnal, sort of, warmly invite you for this event. So I look forward to meeting all of you and welcoming you all. Having said that, I think it's time to start our webinar today, and I would hand it over to our convener for the evening and our president-elect, Dr. Samir Dalvie, to start the proceedings.
Hi, Ashish. Yeah. Thanks for this. I think Gautam, who's really the spearhead behind this, is not able to make it today because of another conference. He's a very busy guy. So that leaves it to Ashish and me to run this through. This is going to be a very, very exciting teaching program. I think I selected lumbar disc because it's the simplest thing and every orthopedic surgeon needs to know about it. And, in something which is very common, there are often some things which are very unusual. And that is what we want to point out here. We're not looking at a normal, usual situation which we know what to do with, but we are looking at something which is a little off the charts, a little different, and what to do with it. So for that, we are so fortunate to have our colleagues across the oceans from the British Association of Spine Surgeons, BAS. And so we will share our views and see, how they function, and you will see how we function. And we will, hopefully be able to spread a lot of knowledge regarding the same. So I'm going to, we are going to introduce. Okay, my screen is seen. Can my screen?
Yes.
Yeah, yes. So I'm going to start by introducing Rajat. You will be able to see him later on as well when I unshare. Rajat, in addition to everything else, let me start by saying is my dear friend and my batchmate, although he was from JJ, and I won't hold that against him because he redeemed himself by marrying my classmate. So he is also sort of an in-law for me in addition to being a friend. So his career has been extremely, extremely illustrious. And he's a consultant spine surgeon, in the UK at Manchester. And he has a great interest in, when you see his achievements, I think the largest thing is safety of spine surgery. And he has spearheaded the concept of 2 surgeons operating together, dual consultant surgeries for complex surgeries. And safety has been a big thing for him. Teaching, academics, research, all of that. He's very, very well known. And he's made a huge name for himself in the UK. Lots of publications and lots of academic work. And really, we couldn't have had anybody better than him to join us. He is also very active in the the medical political scene. And he's right now, in fact, the president of the British Association of Spine Surgeons, which is quite a feat. And he has put together his side of the team, and we look forward to hearing from him. So that's Rajat. Please welcome him. Now, I'm going to say something about Jayesh, and then I'm going to hand it over to him. Jayesh has been my senior at KEM Hospital, and we always looked up to him, and we could ever see if we could follow him. And he became a spine surgeon, and he was in the most famous hospital, that's the RJH, the Robert Jones and Agnes Hunt Hospital in Oswestry. And Oswestry, as you know, has been sort of like the mothership for orthopedics in those days. And then he worked at Alderhay. He's working at Alderhay, which is a superb children's hospital where I picked up my sort of spinal deformity work as well. But I hand over now to Rajat. Rajat, would you like unmute your mic and tell us about the BAS and then about this webinar and then about your colleagues?
Good afternoon. Good afternoon, everyone. From I know it's afternoon in the UK. Good evening at India, 8:30. On behalf of the British Association of Spine Surgeons, gives me great pleasure to join all of you in this worldwide webinar, which is in collaboration with the Bombay Orthopedic Society. BAS, for people who don't know, is committed to advancing excellence in spinal care through education, research, and collaboration. And forums such as this, it brings together colleagues from across the globe, and this is vital in sharing knowledge, challenging our ideas, and finally improving patient outcomes, because that is what we are in the game for. I would like to thank our hosts and the organizers for this opportunity, and I really look forward to the case-based discussions ahead. So Samir has already mentioned my background. I'm proud to be from Mumbai or Bombay when I was there. And I would introduce Mr. Trivedi. He's a very good friend, and he's somebody that I have worked with while we have done some charity surgery in various parts of the world. He indeed is a very prestigious position in deformity world, and he is a senior that we always go up to for advice if we run into any problems. Next slide, please, Samir. And I would like to introduce Mr. Kaushik Ghosh. He's a consultant neurosurgeon with a special interest in complex spine. He works a little bit north of where I work. He works in Lancashire teaching hospitals. He currently is also part of the exec of British Association of Spine Surgeons and serving as a secretary. He also serves on the United Kingdom Spine Societies Board. As you can see, he is well published. He has been involved in creating policies and guidelines which are followed nationally. And he also takes interest in examining both postgraduate and undergraduate students. And with this, I would like to just hand over back to Samir.
Rajat, tell us a little about the BAS. Like, just Rajat, like who does it include? How many members? And is this like the premier spine association?
So the British Association of Spine Surgeons is probably the largest spine society. There is another society called the British Scoliosis Society, which I'm a member of, but there's a smaller society. British Association of Spine Surgeons currently has approximately 650 members. I know that sounds very small from the scale of India, but it's actually a large number of surgeons. This includes both spinal orthopedic surgeons and neurosurgeons. It is primarily a surgical society, but we also have members from the allied health or allied specialties. We have physiotherapists who are members, and we we create policy for the government or help in creating policy to direct patient care. As you know, UK is a system where government pays for everything. So we are helping to provide best value-based care. So primary, our primary aim is to improve patient outcomes, but at the same time, make sure that the value that is being spent on healthcare is achieved.
That's great because, as so I can see the characteristic of your association, which, I would point out. One is that the neurosurgeons and the allied specialists and the orthopedic surgeons have all got together and working for a common purpose, which is really good news for everybody. It's also great that your main focus is on patient outcomes, like, because it's not just research on parties and conferences, it's actually patient outcomes. And what is really heartening is that you work in conjunction with the government to deliver care, and they actually consult with you, because some governments don't really want to listen to doctors, but it's great if this happens. And that I can't see a better deal for the patients and the work which you do. And I know from my years in the UK that in terms of a rational care, it's UK gives the most rational care. Like, you don't go overboard with techniques and technology, because you do what is right. And so you always have a little tempered things. You don't jump to newer things, and that's very, very heartening. And that's why we enjoy collaborating with the British. So Rajat, I'm going to go ahead and introduce the members from the Bombay Orthopedic Society. So Satyen Mehta, again, my friend, very prolific. He is attached to the Hinduja Hospital at Khar, Fortis, USS Hospital at Chembur, and has his own clinic. He is also very illustrious. He's a gold medalist and has had fellowships really in many places in the world. Lots of publications and presentations, and he was one of, I think, almost the founder secretary of the Bombay Spine Society, which is sort of very important. And he's also a mentor for a spine fellowship program. My friend Mihir Bapat, again, Mihir Bapat trained at JS Medical College in KM Hospital. He sort of followed like a few years behind me in the same route which I did, with our trainer and mentor, Dr. Vijay Lahiri, which I'm sure everyone has heard of him. And then I followed him because he was in Hinduja, and then he left and went to another hospital, and then I joined Hinduja. And he's now the director of spine surgery at the Nanavati Max Hospital, which is one of the like major hospitals here. And he's also the president-elect for the Bombay Spine Society. And he runs 2 fellowships, but the ASSI, which is a national fellowship, he runs that as well. And he's a great teacher and a great surgeon. Agnivesh Tiku as well is joining us this time. In addition to, I think, his role as the webmaster and putting the technicals for this webinar together, I think I must appreciate him for that. But in addition to that, of course, he's a great spine surgeon. He's done his fellowship in spine surgery under a great mentor, the mentor being me. So I think he's very well trained in spine surgery, and he's at the Apollo Hospital, which is a huge hospital in Navi Mumbai, which is coming up. Very academic, lots of publications, presentations, and book chapters. And he is an executive committee member of our spine society. Last but not the least, me. I think I don't want to say much about myself, except that I'm at the Hinduja Hospital and I'm the president-elect of the BOS. And I am hugely associated with the AO Spine, where I was the Indian subcontinent chairperson and a trustee. I too run fellowships, and I have 4 fellows who I train for their program and the exit exams. So, so much for us, and we can start off straight away. I would invite Jayesh to share his screen now. We see a lot of discs at various ages, but sometimes we get flummoxed when a very young patient comes to us, like an adolescent. And, Dr. Trivedi is going to tell us. So just a side word to all of you who don't know this, who are from India. You must be wondering why they're called Mr. So it's a great honor because, in the UK, if you're a surgeon, once you get your surgical qualification visit the FRCS, you are called Mr. So we are not disrespecting them, we are respecting them even further. So, Mr. Trivedi or Jayesh, I hand over the proceedings to you.
Samir, thank you very much for your kind introduction. It's not only a pleasure, but a privilege to be able to be associated with Bombay Orthopedic Society because, as you know, it's my alumni. having trained both in GS and KEM. And it is heartening to see that it has progressed so much since I was a resident in Mumbai in KEM. So, and this is all thanks to people like yourself, Gautam, and all the members you mentioned recently. So thank you very much for this opportunity. The topic for me is adolescent disc herniations. Now, we know that teenagers have a lot of tension issues, be it financial, be it to do with their partners, but a legitimate teenage tension is an adolescent disc herniation. Before we go on to the case mix today, I would just like to briefly share the epidemiology because it's slightly different from adult disc herniations. We are all familiar with adult disc herniations, but the adolescent runs a different pathway. Firstly, the incidence is less than in adult population. And as you can see there, in a big series of patients from the Mayo Clinic, looking at 6,500 patients, only 60 adolescents were noted to have disc herniations. The incidence changes in different parts of the world. Japan probably has the highest incidence, and this is largely because adolescents in Japan are asked to get to working a lot sooner than adolescents elsewhere in the world. As in most spinal conditions, there is a male preponderance, but interestingly, if under the age of 16, females have a slightly greater preponderance for disc herniations. As we see, obese patients are more likely to have a disc herniation in their adolescence. Etiologically, there are three factors that are important as predisposing factors towards disc herniation. Almost a third of these patients will have a history of trauma. And this is mainly sports-related trauma. So many of the patients in the adolescent who sustain disc herniations are actually high-achieving athletes, as opposed to the adult population where it's a manual job that predisposes you to a disc herniation. Congenital anomalies, predominantly at the lumbosacral junction, is also thought to be responsible for increasing the incidence, like either having a transitional vertebra where L5-S1 may be conjoined, or if you have a Bertolotti syndrome, which is where part of L5 is partially fused to the sacrum. And the third important factor is a strong family history. And this is quite nicely highlighted by this study by Gunsberg, where he looked at adolescent disc herniations in twins, where the prevalence was 32% versus 7% in non-twin environment. So this slide highlights what are the etiological factors in this patient population. Symptoms of adolescent disc herniations differ from adults. Mainly, the pain is localized to the back instead of having typical sciatica that we are all aware of. The child will often complain of stiffness, which in a high-level athlete is quite gutting because it does not allow them to play their sport. And this leads to reduced exercise tolerance in their respective sport. Many are referred to the general orthopod or physiotherapist as having scoliosis, as we shall see subsequently in the case presentation. And the history is quite prolonged because the diagnosis is not quickly established. And thankfully, there is a paucity of neurological symptoms in these patients. So very few have any muscle weakness or sensory disturbance, as I've highlighted. In fact, the most pathognomonic sign in these patients is a reduced SLR, which is probably sometimes the only sign that you see in these patients. So let's look at some cases. My first case is a 16-year-old cricketer who plays at a high level, county level, which perhaps in India would be equivalent to a state level, was actually referred to me as having potential scoliosis. And in his history, he had low back pain for 3 months. And on examination, there was no structural scoliosis. There was no rib hump, etc. But the most striking feature, as I discussed earlier, was quite marked restriction of SLR and a depressed ankle jerk. So these are his x-rays. As you can see, hardly any scoliosis, certainly no structural changes, and an MRI scan confirmed the presence of a left-sided disc herniation at L5S1. Moving on, case number 2, again, a very high-level tennis player, plays for his club, etc., injured his back whilst playing, apparently, and complained of leg pain only restricted to the hamstring area. What was interesting is that this guy's mom was a physiotherapist, and she was treating him for an injured back for quite some months before she accepted defeat and got us to see him. And clinically, he had a very restricted SLR. These are his x-rays, some narrowing of the disc space at L5S1. If you look at the AP x-ray, you will just about see a faint calcification, possibly within the canal, and I'll come to that in a moment. But these are his MRI scans, and this is an entity that we need to be careful of or aware of when we look at adolescent disc herniations. As you can see, his disc spaces are reasonably well preserved, but the axial image shows a lesion within the spinal canal, and that lesion is actually an apophyseal separation of the ring apophysis of the vertebra. This is a very common entity in adolescents. They have ring apophysis that have not yet fused to the vertebral body, and you can see this on an axial CT scan where there is calcification within the canal. So apophyseal separations are typical in adolescents. There is almost always a preceding history of trauma, and is characterized by persistence of symptoms because the body can't resorb the apophysis. 3 types have been described. Type 1, which is only cartilage. Type 2 is associated with the rim of the vertebral body, and type 3 has a proper defect in the vertebral body. So those were the 2 cases, one an apophyseal separation, and now coming to the third case, which is a 19-year-old university student training to be a hairdresser, 12-month history of back pain, but only 3-week history of leg symptoms. And clinically, no sphincter issues, but a very typical waddling gait that we normally see in patients with high-grade spondylolisthesis from tight hamstrings. And this is her MRI scan, which reveals disc degeneration at the lower 2 levels with a right-sided disc herniation at L4-5, but a massive disc extrusion at L5-S1. And you can see that on the axial images. This would normally have precipitated a cauda equina syndrome that Kaushik will speak about later on in his talk. But thankfully, in adolescence, because the spinal canal is quite wide and because the nerves are quite pliable, they don't tend to get cauda equina syndrome. They typically present with leg symptoms and hamstring tightness. Investigations we talked about. Coming to treatment, the usual non-operative treatment consisting of painkillers, physiosuppression, rest. Interestingly, there are a few papers looking at chemonucleolysis, which is the injection of chemical substances within the disc. For those who are not familiar with, it was a big fashion in the early and mid-80s to dissolve the disc using chymopapane, which is an enzyme obtained from papaya, but not used in adults because it gave rise to significant inflammatory changes. I must say that non-operative treatment for some reason in adolescents as opposed to adults doesn't turn out to be as successful. We can have targeted nerve root injections, and usually surgery becomes the modality of treatment. Looking at results, there are scattered papers looking at non-operative treatment, the biggest being from Karadamir, where they looked at 72 patients and 60 of these did well with conservative treatment, but 12, so a fifth of those patients actually converted to surgery. And then the last paper on this slide looked at return to play in high-level rugby players, which is a typical sport that is popular in the UK and some of the Southern Hemisphere countries. And they looked at the meta-analysis of treatment, and they found that the return to play at the highest level was similar between conservative and non-conservative treatment. And this is the final case that I have, a 15-year-old, not a high-level athlete, back pain and right-sided symptoms for a year. These are the scans in 2021. And you can see in 2022, the disc has become bigger. And we tried to treat her with a CT-guided nerve root injection, which is what I tend to do in all my patients, including adults, rather than doing it fluoroscopically. Sadly, didn't make a difference and eventually ended up having discectomy. So all of the 4 cases that I kind of showed earlier all ended up having surgery. And that has been my experience, that adolescent disc herniations probably don't do well with conservative treatment for some reason, largely perhaps because they waited so long for their diagnosis to be established. The surgical methods, microdiscectomy, standard endoscopy now, and in some papers, fusion, particularly if there are significant degenerative changes. Results, if you look at the meta-analysis, all report of excellent results with surgery. Just a word of difference between adolescent and adult disc herniations. If you have the apophyseal separation that I was talking about, you are likely to find cartilage and firm bony tissue during your canal. So it is advisable that you do a wider decompression than what you would do in a setting of a normal disc herniation. Sometimes the disc material is quite squidgy because that cartilage is still quite hydrated. So that's the difference between adolescents and adults. And just briefly summarizing the difference between adult and adolescent disc herniations: lower incidence in adolescents, degenerate disc. So adults will never prolapse a disc unless it's first degenerate, whereas adolescents can even herniate a normal-looking disc, and look out for apophyseal separations. Neurological symptoms and signs that are very common in adults are less likely to be the case in adolescents, but a giveaway sign is a reduced SLR on the affected site. As I said, conservative treatment, probably the first port of call in adults, not as successful in adolescents, and surgery is equally effective in both populations. Thank you.
Thanks, Jayesh. So basically, the question here, Jayesh, is that forget the literature. In your experience, do you feel that these people behave? You can unshare your screen. That these people behave differently from the adults. Like, did you feel? Do you like when an adolescent walks in with a problem? Well, I know your system is different from ours. Ours, all patients walk in, but you would only have referred patients. So when you get an adolescent patient coming in referred with a disc, do you find something different in them?
Yeah, so firstly, as I was saying, Samir, the history is quite long. Number 2, they don't tend to present too much with leg symptoms. When they walk into the clinic, you will immediately notice that they don't have a purposeful stride. They kind of hold their hamstrings back a bit. And you will find that almost every patient of mine has had a reduced SLR on that side, which is sometimes the only sign that gives away a disc herniation, as opposed to just back pain in these individuals without a disc herniation. So if you have an adolescent with back pain but normal SLR, almost always it rules out a disc herniation.
Okay, and do they sort of? So you are saying that they have more of back pain than leg pain? Is that it? Like,
correct?
They come with back pain.
Yes.
But so, then, if they have only back pain and they have no leg pain, and they don't sort of get better, do you still offer them surgery for that, for just back pain? And then if you do, and if it's only back pain, then is it then a discectomy or is it a fusion?
No. So if the MRI scan reveals that there is a disc herniation, then I'll only do a decompression and a discectomy. I hardly offer fusion in the adolescent group unless there is significant degeneration at that level. It will be mainly a discectomy for these patients. So my normal algorithm would be, if there is a back pain patient who has had the back pain for greater than 3 months, and because we are duty bound to investigate adolescents once they have had back pain for more than 3 months. That's our protocol.
Nice.
So
nice.
So you almost always get an MRI scan. And if the MRI scan reveals that there is a disc herniation, as I said, my first port of call would be a nerve root injection at that level to see if it eases off the symptoms. but I've not had a successful, as opposed to my adult population, I've not had any success in treating adolescents with nerve injections. A large percentage actually converts to surgery.
Yeah, so conservative doesn't work so well in the adolescents. So before I want to make a few comments, and we'll ask Dr. Agnivesh to see if there's any questions in the chat box. Does any of our other faculty have anything, a question or a word of wisdom to say about adolescent discs? Anything which has not been said so far? Yeah, Rajat, unmute.
I was trying to find the raising hand function. I couldn't find it. Just one comment that Jayesh, when you see the younger athlete with a disc prolapse, in a small proportion of them, they will have a pars injury as well. It's not very common, but it is not that uncommon. In those cases, what is your kind of approach to these?
That's a good question, Rajat, because they are all associated, most of these things are associated with high-level sport. So in these patients, as Samir was saying, if back pain is an issue, I will initially block the lysis and see if it gives them relief. So if the lysis block doesn't give them relief, then I kind of go down the route of being more interventional with these patients. And that generally means follow the lysis block with a nerve root block. If the nerve root block also doesn't work, then I will go down the route of surgical fusion in these patients.
So Jayesh, you had two patients one was a cricketer and one was a tennis player. So what is your experience about them returning to, because I too have a guy who is a pace bowler who, now he's playing. In fact, so what is your experience with them returning after surgery?
So the three patients that I showed initially, they were reasonably high-level athletes, not national level, but at a county level, and they all returned to their sport. So the tennis player went back to playing tennis within actually 2 months. I was a bit wary of that, but because he was under pressure because there were qualifications and selections, and the cricketer was actually a bowler, and he too returned at about the 3-month stage. So they all kind of returned to the sport. I don't know what it would be like if they were at a very high level, but I see no reason. That paper that I quoted further in the talk, in fact, revealed that they returned to very strong, physically contactable sport like rugby as well. So I think the incidence of them returning to their original sport is quite high with surgery.
Great. Because I did one, and he is now playing for India under-19, which is immensely more competitive. So I actually told him you're never going to play again, but that's what happened. So I know let's just, I'm going to try and involve Mihir. Only answer one quick question. I know you like fusion. I don't want to paint you as a guy.
Not in these groups.
No, that's exactly. So in adolescent disc, bias more towards fusion or bias towards not fusion?
No fusions. No fusions.
No fusion. Okay. And Dr. Kaushik, as a neurosurgeon, you must be having a maybe a different patient profile in these adolescent discs. Do you see them commonly, and do you see them more going towards surgery, or by the time they come to you, they are already surgical candidates?
Yeah, I put my hand. The reason is I wanted to share a couple of observations. I know Jayesh has presented with a high profile sort of sports people, but in my practice, I have seen more recently, in last 5-7 years, the incidence has become higher, and the patient profile I have dealt with, none of them were very high profile sports people. But one thing was noticeable, majority of them were obese. So obesity could be another reason which could affect at this age group. And I am never in favor of fusing this group of people unless really needed for some reason. Right. And just wanted to mention what Joyce has already mentioned, the discectomy becomes a bit different to adult discectomy because their discs are usually not degenerated. And I try to stay as minimal as possible. So don't want to go too much into the disc. Just look for free fragments and the one which is pressing on the nerve and release pressure on the nerve and do minimal.
Satyan and Agnivesh, if you have anything different to add, we'll add, or if you agree with all of this, then we'll just go on. So my little concluding remark is that, and I worked with Gordon Findlay, as you know, I don't know, he must have done more microdiscectomies than anybody in the world. I don't know how they all gravitated to him, but he always said that these adolescent discs are different. They are like, and to use his words, it is like what comes out of your nose. So it's like that. It looks like mucus. So when you open them, you do not get the satisfaction of getting a fragment as you get in adults. You don't get a fragment. It's literally like you open it and it just squishes. It keeps coming. You don't even know when to end, because unless, like you said, there's an apophyseal cartilage, it just keeps coming out. It's just like literally like mucus, as if somebody you got a bad cold over there. And then probably then the bulb sits down. But these patients do well. Like, I mean, I think those who have operated, they've all done well. So anyway, that's great. That is a great topic. Thank you very much. I'm going to now carry on with the next topic, which is my topic, which is which is on far lateral disconnection. I'm having some problems. I'm sorry. No, this is a different page. I'm sorry. Just give me a second. I think I'm having a problem here.
While you're sharing, can I just ask Jayesh about?
Say something.
Here it is. Yes, there.
Yeah, Rajat, you want to say something? That's fair enough.
I was just saying, do you find the recurrence rate higher, Jayesh, for these patients or not so?
No, I haven't seen that, Rajat. I think my practice for adults mirrors yours. I will try my best not to do a discectomy in adults because it just is heartache. And I know we have a talk on persistent leg pain after discectomy. I will keep treating them with nerve blocks if necessary. Whereas these kids, they do extremely well. I'm quite happy to kind of do surgery on them.
Thank you.
Fine. So I'm going to speak about this. There's a 56-year-old female who came to me with 8 weeks of severe unilateral leg pain. Really pain out of proportion compared to other patients, along the dermatome, restricted straight leg raise, and weakness as well. And patients never come to us unless they have lots of conservative care. So I'm directly putting up this MRI because, I think this is not to teach really novices. But the point is that in an MRI, this is very often missed by radiologists as well, and orthopedic surgeons as well, and some spine surgeons. So this phenomenon, because in the normals, in the sagittal and parasagittals, you don't see it. But what you see it is in the axials. And what you see here is this, which is a far lateral disc. And I'll come to what is a far lateral disc. If you get a very good keyhole image, then you can see it as well. But you may or may not get it. And sometimes you get it even in these images. Like if you get it in these images, you can see how beautifully seen it is. So this is the so-called far lateral disc. And what is this far lateral disc? I mean, most of the discs which we have are those which are posterolateral, the common one. There can be some central ones. But this one goes out. And what it does is it doesn't hit the traversing route. It hits the exiting route. And it's very difficult to sort of see it in a normal MRI. You have to really keep your eyes open, to look at it, especially if a patient is going on complaining of leg pain. And to just give a sort of minor anatomy lesson, as you can see here, you can either have these central discs here or these ones, which are the sort of standard ones which we have. Then sometimes you get a foraminal disc, which is just below the facet. But the far lateral one is outside. It's lateral to the facet. And, I don't even know how that really happens, because as we know, the sort of annulus is deficient over here and, where the next to the PLL. But you do get these sort of far lateral ones. Again, to show you another different sort of thing, the foraminal is below the facet. But this one is actually lateral to the facet, and it happens, So this was reported as an extreme lateral disc. And in this first series, there was 7% to 12%. So approximately 10% of all disc herniations. But I would say it's much less than that as far as I'm concerned. I would say it's maybe 5%. And what is different here is that the dorsal root ganglion is there. And this is something which has always been told to me by Gordon Finlay, that the pain is out of proportion because of the dorsal root ganglion. So there's a lot of pain and a lot of paresthesia. In fact, to the point that even after the disc gets better, this patient still has pain. And it's intractable pain, and patients scream really with pain. And they don't have much back pain. If they have back pain, it is because of degenerative change, and it may not be really related to this. So what happens is, especially if you have a sort of a L4-5 or you have an L3-4 level herniation, you often hit the sort of L3 or the L4 nerve root. So you may have sort of a lateral or an anterior thigh pain, and that's another thing which should sort of make you aware of that, because they're very common at these two levels. And then the pain won't be the classic sciatica. It will be more of lateral or anterior thigh pain. And these patients sometimes have a weak quadriceps. So they'll tell you that they buckle when they're walking, or they are, they can't get out of the chairs. And, that's another thing which should sort of act like a red flag. So like I said, on the MRI, you need to really look very carefully at the axials. Yes, if you can pick them up in the parasagittal or the keyhole cuts, that's great. But the axial cuts are really what give you an idea, or which tell you where this cut is. And again, this is a book picture just to show you how this disc looks like and what it does to the exiting nerve. So not to the traversing nerve. Coming to the management, many of these patients are in a lot of pain, but the first line of treatment still is a nerve root block. And a nerve root block initially does help quite a bit. And it's because of that ganglion that sort of the pain settles initially, and you may have to repeat the nerve root block. But often what happens is these discs become hard, and then, this doesn't work. And then you need to go down the surgical route. And in the surgical route, there is a whole bunch of different stuff. So either you can do an open or a midline surgery, or then you can do some sort of minimally invasive surgeries, which I will sort of talk about in a minute. And how do you actually reach to it? Because the question is that it is at a very awkward position. It's actually lateral to the facet. So if you go down your usual paraspinal route, you may not even see it. And then you may end up having to remove the facet. I'm going to ask Mihir about this, because Mihir once told me that he can get it from the middle and he does partial facetectomy and reaches it. But to my mind, I would say that, if at all you're going from that approach, you're going to have to remove the entire facet. And therefore, the paramedian or the Wiltshire approach is the one which is the sort of preferred approach. But since this is, I'm just going step by step. So one can still go with the medial one, because it's the familiar anatomy for most surgeons. But the problem here is that you will end up really damaging the facets, and you may really miss something which is lateral or which has migrated superiorly. So this is not, you really have to remove a large part of the facet to get there. So therefore, it's the extraforaminal route or the Wiltshire approach which we use for fusion, which really works, where you actually land up with your retractor on the facet. If you take a midline incision, it is impossible to reach there because you really have to dissect a lot. But if you take a paraspinal incision, you can just put your finger in through the muscle plane. You can reach there like a Wiltshire approach and sort of approach it. And it's like a very beautiful approach, because there is very little muscle dissection. There is actually no bleeding. And you really land up on the lamina and on the lateral side of the facet. And that you go down the junction of the transverse process, the facet and the lamina. And there is a membrane over there. And if you dissect that membrane out, and you will immediately see the nerve root right below the membrane, because it's pushed up by the disc. And you just retract the disc and the disc pops out. And this is if you do it at the right time. Like if you do it not too late when it has become too hard, and not too early when it's too soft. So if you do it at the right time, you just dissect the membrane out lateral to the transverse process, and the disc just pops out when you retract the nerve. You don't need to do too much. This discectomy is not like your conventional discectomy where you need to enter the disc space and keep taking out disc. If that is what you do, you just need to remove those fragments which have come out, and the nerve is not compressed against anything. So that way, it works quite well. So this technique from the paraspinal, one can do it with an incision and a Wiltshire, and you can put in a McCulloch retractor and do it. But with the tubes, it has become sort of even easier, because you can just dock your tubes over there And then you can still do it with the microscope if you're used to doing with the microscope. And the newer guys now do it with an endoscope. And I'm going to ask the British guys whether endoscopy has really picked up there. But I am told by the endoscopic surgeons that doing a far lateral disc endoscopically is a challenge, because they tend to actually hammer their endoscope into the far lateral area and make a hole and take out the posterolateral discs from there. So if they need to remove a far lateral disc, then they have to keep the endoscope floating. So I'm not sure whether the endoscopic guys really are the best guys for this. But this is what I do now. I would do this tubular discectomy, because that works very well with the least tissue damage, and you land up there and you beautifully see the nerve root sort of below the pars. So the most important step in this is to take off the membrane. So if you take off the membrane, then you get the disc right below that. I think the most important complication is your pars fracture, because if you don't get it and you start sort of fiddling around and you start removing bone, then you may remove the pars or you may remove the facet, and that will cause a problem. And if you're not sure of your anatomy, you can really knock off the nerve root, because the nerve root is pushed back and up towards you. So I think that's also an important thing to keep out. Coming to a slightly different case, again, this patient came with similar symptoms. And just to show you that in the sort of normal sagittal MRIs, which most novices will look at, there's not much to write home about. But this patient has got this disc. Now, if you see, this disc is a little different than the previous one, which I showed. And this is lying a lot below the facet as well. And this patient came pretty late. I also don't like the consistency of that disc. And I think it's not going to be a soft disc. It's going to be like quite a hard disc. And in addition to that, it's at L5S1. So at L5S1, one of the problems is that the iliac crest comes in the way. You don't get the same, the ala comes in the way. So you don't get the same approach through the far lateral as you get at L4-5. So an L4-5 or an L3-4 far lateral is like it's a beautiful case. It's a 20-minute case, because you are down there and you're just out. There's nothing much which you have to do. But at L5S1, the ala comes in the way. So you don't really get to approach it in the way that we do for the L4-5. And this is again something which Gordon Findlay taught me. And he used to remove the facet. But now I don't think I like removing facets without doing something about it. So though this patient may not have needed a fusion for any other reason, but because we remove the facet to decompress, so I would first try to see whether I can get this disc out through the paraspinal. But if I can't, then I would go ahead and then do a fusion as well. So that's my 2 bits about the far lateral disc. And I think Rajat is supposed to be the sort of...
Yeah, so if there are no more questions, I'm just going to bring Mihir in, because you started off with this comment about Mihir's technique of using partial facetectomy. Mihir, what is your view
I
on
hope
that?
he agrees. He said it once, so I don't know whether he's still with it.
No, I still do it that way, in the sense, though we believe that these discs are far lateral, there's always a tail which is under the pars. And if you trim your facet well and maybe undercut your pars, you have an excellent view with your microscope looking under the pars, and you can tease this tail out and you can almost get the whole disc out. And it just takes about 20-30 minutes to do it like a conventional discectomy. So I think I've been doing it for years. And we have done our share of, we'll say, approaches, and they are good, but you can still do it the conventional way without damaging the pars and the facet, because we've never had an instability.
Okay, thanks. Before I ask Kaushik to comment on endoscopy, can I just ask you the intertransverse membrane that you refer to?
Yeah.
Do you use a particular technique to take it down?
Yeah, so we basically, I would, with the diathermy, or what we call in India as the cautery, we would sort of denude the transverse process and the bottom of the transverse, the inferior part of the transverse process, going along the facet and along the pars. And after that, I would use a curette. And with that curette, I would just remove that, it's a beautiful step. With the curette, you remove the lamina, you brush the curette from lateral to medial, and that whole membrane just comes off.
Yeah,
And
so I think it's important. I think it's
you
important
can
to kind of...
tremendous bleeding if you're not careful. So do it under the microscope. Yeah.
So it's important for viewers to know that it is done mainly either indirectly or blunt dissection. We don't use any sharp dissection, blindly putting a kerosene under the membrane until the membrane has come off and you can visualize the nerve. So that point was well illustrated. Kaushik, your comment on what UK experience. I know what my views are, but I'll share it after. But your view about endoscopic indications for this?
Yeah, I mean, endoscopic, first of all, disclaimer, I don't do endoscopy. And I was very, very skeptic, but less skeptic these days because I had an opportunity to see more endoscopic cases. I think there is a role. It is a bit over exaggerated still, I feel, but there is a role. What Samir was saying is absolutely right. When there is extra foraminal disc, then you can't dock the endoscope. So throughout the process, you have to hold it. So that makes life really difficult. But far lateral disc, which is still within the foramina, endoscopic disc is quite ideal. And amongst my cases, one of them was endoscopically done. I'll show you. So there is a role, I feel. And in UK scenario, the number of surgeons doing endoscopic disc is slowly rising. You know, in Manchester itself, in Salford, it was started by Saxena, but now quite a few surgeons are doing. And they are presenting good results. But I personally feel it's more important for lateral disc, for very lateral, interlaminar. I don't see much advantage of doing it endoscopically.
Right. There's a more of a comment than a question on the YouTube. It says that with an outside in technique, it is much easier, but inside out, it would be awkward. I think the user is referring to transforaminal endoscopy versus an interlaminar endoscopy. So any of the faculty can take that.
Yeah, that's what exactly I was saying, Agnivesh, that from outside it's easier rather than going from inside. Now, just adding to what Mihir was saying, in my experience, not the extraforaminal, but majority of transforaminal or far lateral disc, I manage with traditional way. Go a bit more lateral, a bit more partial undercutting facetectomy. But the philosophy is if you can reduce the intradiscal pressure adequately, then that helps with the patient symptom.
Thank you, Kaushik. Do we have time for another question, Samir?
If there's a question, we can ask it for sure. Or otherwise, we can then move on to the next. You have a question?
I was just very interested in because I guess the patients present to surgeons like you, Satyen, and Mihir, Agnivesh, fairly early. We see them probably 6 weeks, 3 months after. If you have seen a patient where their acute pain, because it is a very painful condition, as you pointed out, very dysesthetic, and you can get wasting of quadriceps, but the pain has disappeared, but they're left with wasted quadriceps. What is your approach then? Do you still want to do surgery, you think? Is there any role for surgery there? Because the pain is better now. You're muted.
I think the treatment of disc, other than in cauda equina, the treatment which I'm we'll segue into that as well. So other than that, I think to my mind, the only indication for surgery for disc is pain. Any patient who doesn't have pain, irrespective of the MRI finding, I don't do surgery. So if he's left with a quadriceps weakness or wasting, then that will come up as well. There's nothing to be achieved more by doing surgery than by not doing surgery. But once the pain is gone, I think I would not operate on such a patient.
Okay, thank you. Jayesh, you have a comment to make?
Just a comment, taking up on the symptoms. I agree with Samir. These far laterals, particularly where the DRG is, tend to be very painful. But the other thing that I've noticed about these, so in normal disc herniations, when I mean normal posterolateral, patient prefers to lie down. Whereas in these far lateral discs, symptomatically, they find even lying down very uncomfortable. So many of them end up sleeping in an armchair, etc. So that is often a giveaway to these foraminal and far lateral discs. if they say I find lying down uncomfortable, it's usually extra foraminal.
That's true. One of my colleagues at Bombay Hospital who did his rotation in the UK came to India and then got this far lateral disc. And he said he didn't lie down for 3 months and he went seated in his flight back to his mentor in the UK to get that surgery done because he couldn't lie down, he couldn't sit. So yeah, that's true. And often, but blocks help. So Rajat, the patients, we both operate at around the same time. So they come to you later, referred. They come to us on day one, but they don't get operated for a very long time because most of our patients, they don't want surgery. So they will try everything. So if you operate your guys 3 months down the line, I think our guys also are operated 3 months or even worse, because unless they are motivated or we can convince them for surgery, most of the patients want to avoid surgery and they will keep going from one surgeon to the other until somebody says, no surgery. So
I'll come to you in a minute, Kaushik. I think Mihir had his hand up. Mihir, did you want to make a point?
No, actually, when we tackle these two scenarios, I think extraforaminal is an entirely different ballgame when it comes to a disc within the foramen, because that entity is extremely painful, but an extraforaminal one will resolve in a reasonably short period of time because there's ample amount of space for the nerve root to adjust. So really, these two entities are different, and if you block these, even if you give a block, the extraforaminal ones resolve very well, but the transforaminal ones, they usually tend to linger on and they have their own resolution over a period of 6 to 8 weeks. So it's a time-taking process, and I think counseling matters because otherwise it's very easy to push these patients into surgery because they're extremely painful.
Okay, thank you. Sorry, Kaushik, can I just get Satyan's view and then I'll get you in? Sorry.
Yeah, I actually had a question for the entire panel, especially for Dr. Dalvie. See, most of these patients that come to us, they come to us maybe 3 to 6 months after trying out all various types of therapies. So these discs are no longer fresh disc herniations. And would you still attempt a same Wiltshire approach for them, or would your approach change? Because I don't know whether it would be as easy to just tease out the extruded fragment, considering that it's 6 months down the line.
I think for the far lateral, which I was speaking about, or if you could see the first MRI which I showed, I don't think I could possibly reach it through the midline. So I will still do a Wiltshire. And I'm quite confident I can enter the disc. And see, now we've started doing, our combined experience of micro plus MIS TLIF plus this makes this a very easy approach. It's like a very familiar approach because I anyway use that approach for doing my MIS TLIF. It's just a little more lateral than that. So the only thing you have to do is not damage the bone. But I don't think my approach changes. And in fact, if these patients are a little late, they have a nice discrete fragment and there's just one big fragment and it just comes out, where the nerve will be compressed. You just shift the nerve and the fragment pops out. So yeah, I think that won't change my approach.
Dr. Kaushik has his hand up.
Yeah, Kaushik.
No, just wanted to make one comment. What Samir was saying, the only indication for discectomy will do for pain. But there is a common scenario we encounter quite often. Patient's sciatic pain has improved but developed foot drop. So I personally still offer them surgical decompression if they are within reasonable time frame.
So I think we can, there's going to be a little disagreement. What happens is that a painless foot drop, operating a painless foot drop is something which I don't do. And I tell the patients that maybe you'll benefit from surgery, but I don't do it. And then I send them to Satyan. So, right, because I'd rather not answer that because I feel we are not achieving anything by doing that surgery. It doesn't have pain. And the foot drop is either going to recover or not recover. It is not related to surgery. That's what I feel. But I guess there is also a point of where a patient may accuse you of not doing anything. Like so it's a tricky situation. Like a painless foot drop, Kaushik, is a very tricky situation.
So,
but I'm going to segue into that. And we can, in the interest of time, ask you to share your screen and speak about.
So while you're sharing your screen, just keep an eye out because BAS is working on a foot drop pathway, so it will be coming out.
Great. Kaushik, tell us about cauda equina syndrome. It's like the bane of our spine surgery.
Let me just share. Can you see?
Yes, thank you. Yeah, carry on.
So good afternoon, everybody, ladies and gentlemen in UK, but I am mindful good evening for our Indian colleague. Thank you again very much for inviting us from BAS to be part of this 60 years of Bombay Orthopedic Society. Really grateful. Best wishes to you all. So the topic given to me was Cauda-Equina syndrome from back pain to bladder alarm. I'm a bit outlier, I can see, both in the sense I'm not a Bombayite, either before or present. I was grown up and trained in Kolkata, and I'm a neurosurgeon, but I have a special interest in spine, so I'm more integrated towards spinal side now. So what is Cauda-Equina syndrome? Cauda-Equina syndrome is a constellation of symptom and sign because of pressure on the nerve roots within the cauda equina in the lumbar spine below the conus. And it is confirmed with imaging. So that combination forms cauda equina syndrome. Now, there are a variety of etiology of cauda equina syndrome. The common one we deal with is lumbar disc prolapse. But in slightly elderly age group, degenerative lumbar canal stenosis is not uncommon. Other causes are spinal tumor, be it primary, intradural or extradural bony or metastatic spine, which is becoming more and more common because of aging population, and more people are living more with cancers. Trauma, infection with epidural abscess, we deal with quite often, and other less common causes can cause Cauda-Equina syndrome. But we'll concentrate and focus on the degenerative condition in our talk today. So what are the relevant clinical features which helps us to diagnose Cauda-Equina? Or in other words, it's known as red flag signs. So somebody with back pain, with usually bilateral sciatica, foot weakness, and especially bowel bladder or sexual dysfunction in the form of either retention or incontinence. Signs, loss of anal tone, loss of perianal sensation, and large volume residual urine in bladder scan is considered as indicative of Cauda-Equina syndrome. But I'll come there. Traditionally, these are commonly considered as a key signs of Cauda-Equina syndrome. Now, I was looking at different society websites and named hospitals, and from ANS website, this American Association of Neurological Surgeons, can see a list of red flag signs they have mentioned. So it has to be a constellation of symptoms rather than one or two symptoms. And quite interestingly, they have put urinary retention as the most common symptom. And incontinence happens because of the retention according to what they present when the bladder fills up. So there comes the diagnostic dilemma. When to diagnose a particular patient having a Cauda-Equina symptom? Is there a particular symptom which is more important than others? Or is it a combination of symptoms? Now, this question has always bothered us because Cauda-Equina syndrome has a big implication medico-legally. So we looked, I was looking at literature, and one of these recent ones, which is published from Manchester, where Rajat works, they've looked into more than 1,000 patients and looked at the role of anal tone and perianal sensation as a part of clinical examination to suggest if it is Cauda-Equina syndrome or not. In the 1,000 patients, they found about 11% having imaging positive Cauda-Equina syndrome. But when they looked in details, 35% of MRI positive patients and 31% of MRI negative patients had reduced anal tone. So it has neither specificity or sensitivity. And looking at perianal sensation, their outcome was more or less similar. So we did very similar study previously in Preston. It's unpublished. We looked at 420 consecutive patients referred to us as Cauda-Equina syndrome and looked at three things: the association of perianal sensation, anal tone with PR examination and post-void residual urine. And we haven't found any of this conclusively associated with the diagnosis of Cauda syndrome. As you can see in this one with the sensation, and in this too with the anal tone and post-void residual. In fact, post-void residual urine, the mean was 177 in MR positive and 122 in MR negative patients. So it was not very helpful to diagnose it clinically. And the diagnostic challenge gets worse in patients with adult or more elderly degenerative stenosis. They have grumbling Cauda type symptoms. They have other problems, and their usually age-related bladder bowel syndrome symptoms are already there. Prostate-related sphincter issues, postmenopausal hormonal imbalance, and they can already have bladder problem. A lot of them come and say, when you ultimately assess, that it's actually a weak bladder I'm having for a while. They have coexisting medical conditions, long-standing diabetes, cardiovascular disease. They can affect bowel bladder. And they're more prone to get neurodegenerative conditions at that age. So that as a whole makes the diagnosis quite difficult. So you have to combination with the constellation of symptom, its onset, its duration, and progression. Now coming to progression, does all patient progresses to Cauda syndrome? We all know in our practice that it's quite unpredictable. You can't really predict. Even with a large big disc, patient can have just a sciatica and moderate sized disc having sphincter problems. And very similarly, patient having a reasonably sized disc, but they have never progressed to Cauda syndrome over months, and in fact, the disc has regressed. So prediction of progression is not very easy. But what is more important, that Cauda syndrome, when they are clinically judged as Cauda syndrome, they are medical emergency. So they had to be dealt with time-sensitive manner. And the important part is we have to stop the incomplete Cauda syndrome at that stage. Because once it moves to complete Cauda syndrome with full-blown symptoms and signs, then the outcome becomes much poorer. So the implication of long-term outcome is much better if you can pick up these patients in the early stage. So with that background, I will show a few cases which I have encountered recently in my practice from on-call in last 2-3 months. The first one is a 29-year-old lady who presented with back pain since January 2025, GP treated just with some painkillers and physiotherapy. Then she progressed to back pain, radiating to left leg pain, and it was in March. No sphincter problem, no weakness, and she had an MRI scan which has shown significant size disc bulge, but considering the sphincter, the symptom complex, the patient was advised to have a MSK routine pathway by one of my colleagues who was on call. This patient got a re-referral to me in August with worsening back pain and left-sided sciatica, but in addition, she had a bit of perianal numbness, not a full-blown sphincter issues, and her bladder scan still shown very little residual post-void urine. And this was the scan. So here comes the dilemma, whether this patient with and just to let you know, the scan in March was almost similar. It was not hugely different when she didn't have any problem of sphincter. So with this scan and just the onset of some perianal sensory problem, I can't leave her alone. So brought her in, discussed, done a discectomy. But again, that throws the question whether this should have been done earlier or we could have waited further. Next case is a 37-year-old lady who presented with few weeks history of left leg pain. Right side was completely asymptomatic. She couldn't move left leg, but it was predominantly because of pain-related restriction. But she had a full-blown sphincter problem. She couldn't feel while passing urine. She had few episodes of urinary incontinence. Post-void bladder scan has shown 1,000 mils. And in fact, after I brought her in for assessment, she had an episode of fecal incontinence. And look at the scan. There's no cauda compression. So there was a broad-based bulge, but predominantly left side at L5S1, far lateral, central sort of disc. And this lady, I tried initially with pregabalin, didn't work. Then given her an injection, just worked for a few hours, which was, I think, the effect of local anesthetic rather than steroid. And then she had a transforaminal endoscopic discectomy. All her pain gone, fecal incontinence improved. There was no further sphincter problem. So radiologically, this is not a cauda syndrome, but how can you leave? And the third case, 82-year-old gentleman with quite a few medical background, AF, type 2 diabetes, heart failure, chronic kidney disease, stage 4. He presented with 3 months history of back pain with some intermittent leg pain, which got worse recently. And he got retention of urine. Perianal sensation normal, no incontinence. We stopped doing anal tone anymore after all the studies. His post-void bladder scan was quite significant. And that was his scan. So chronic degenerative condition, grade 1 listhesis at L4-5 with significant stenosis. But this stenosis must be there for long. Is his bladder symptom retention because of pain? Is it because of prostate? Is it because of his long-standing diabetes and cardiovascular disease? So ultimately, I had a long chat with him, and he went ahead with decompression. His pain improved. I did a unilateral micro decompression. Didn't fuse because of his medical condition. His pain improved, and retention gradually got better. So the key is the timeline of treating these patients, because these patients are the major source of medical legal issues in spinal practice. Whenever there is a suspicion of cauda syndrome with constellation of symptoms and signs, they need to get an urgent imaging. And if it is positive, operation as soon as possible, but within 48 hours. Now, when it comes to lumbar canal stenosis, if there is a new symptom or progressive symptom with bowel and bladder, I would treat as an acute disc prolapse type cauda equina. But if it happens with the gradual progression of a few months, in that case, routine imaging and routine treatment. Now, in terms of surgery, in cauda equina syndrome, I always do, in general, interlaminar decompression, so you get a wide decompression rather than a microdiscectomy, even though if it is mostly unilateral, because I found quite a few patients in my practice over the last 20 years, they do come back. Lastly, I wanted to share the national suspected cauda equina pathway we have. As Rajat was mentioning, there are pathways developed, and BAS do get involved in those. This was done under the auspices of GOVT, which is getting it right first time. Now, I'm not expecting you to read all of this, but I want to highlight a few points. One of them is emergency MRI scan as soon as possible, and certainly within 4 hours of patient's presentation. Number 2 is surgery, again, as soon as possible, as NC-POD 1, between 1 and 2, which means whenever emergency theater list is available, but definitely within 48 hours. And the third thing is what, in my view, is still a bit neglected: postoperative care, long-term care for their psychological conditions, mental health from cauda equina. Because if somebody is losing sphincters control, it has a huge implication: social life, professional life, any sports life. So how to support their sphincter, bowel bladder function, and long-term pain. So I think that is quite well addressed here. So in summary, Cauda equina syndrome is a medical emergency. It is the largest source of litigation in spinal practice, at least in UK, and I think in most places. The diagnosis is based on a combination of clinical signs and symptoms rather than one symptom or one sign. Imaging should be done with a strict timeline, and surgical treatment in positive patients should be done as soon as possible. But important thing is to also look after by appropriate people their ongoing pain, mental health, and bowel, bladder, and sexual health. I'd like to finish inviting you all in our next British Association of Spine Surgeon meeting in Aberdeen, April 29th till 1st of May next year. So you all are very welcome to join us. Thank you very much.
Thank you, Kaushik. That was, very, all-encompassing lot of evidence and a lot of personal experience as well. So Cauda equina syndrome is a bit of a bugbear to our practice. On one hand, it is one of the very few solid 100% indications for surgery. Like there's nobody who will argue with this as an indication for surgery. On the other hand, in terms of outcomes and results, and as you rightly pointed out, litigations, it's quite a bit of a problem. So I think one of the questions that I've been here for a long time, speaking to people and seeing how these things have evolved. And the thing is that this 48 hours is a bit of an arbitrary thing. And I think there is a bit of wink about 48 hours. I think 48 hours was wink because there are people who don't have the facilities to do it ASAP. And the previous guideline for this, if you actually look at the papers, it's 6 hours. So I think 48 hours was an agreed sort of thing between spine surgeons because everybody doesn't have the facilities or the sort of infrastructure to take up a patient within 6 to 8 hours. So when do you actually take up? Like I'll be very honest. If a patient comes to my clinic, I take up the patient the same night. I do not wait. Like I will not say it's 48 hours. It's taken up the same night. So Kaushik, when would you take up a patient? A patient comes to the clinic in the morning or the casualty, the emergency room with a blood.
I'm sorry if the message has wrongly gone forward. It should be ASAP.
Yeah.
So 48 hours is the timeline set for maximum. And I think you were right. The facilities, the availability, MR scan, etc., was taken into consideration. And in the longer term, we have to think about litigation because these guidelines have a very high, point for litigation side. Because if this guideline says within 48 hours, at least that will protect a bit. But in my practice, as you say, if it is a young patient with an acute large disc, I'll do it overnight. If it is lumbar canal stenosis, grumbling for a bit longer, I'll not do it overnight, I'll do next day.
And what do you do in terms of documentation for these patients? Like, how do you document it? Because you see a lot, we have a lot. I think, especially in India, and that's another reason why, I don't know whether Satyan may like this or not, but I have sent him quite a few Cauda equinas for the bladder guys, because what happens is I feel they don't recover. And over a period of time, there are two problems. One is their memory becomes blunt. So like today, if you ask him and he'll know, yes, I can't, my bladder is gone and you're doing my surgery. But a year down the line, if he comes to me or he goes to somebody else, he will actually tell them and say, "Ki, I was okay. And after surgery, my bladder went." And this is what he will tell them. And when patients come to me like this, who've been operated elsewhere, I literally grill the patient. Ki, is it post-op? Is it pre-op? Is it post-op? Is it pre-op? And patients either don't remember or lie. The other problem is that these patients, often they come with this Cauda equina syndrome and they don't know. We ask them and the bladder is gone. And we put in a catheter during surgery. And the problem is the catheter, you can't take out the catheter post-op. And that's when they say that before surgery, I was okay. During surgery, we had a catheter. And now the catheter, this problem happened because of surgery. So how do you document this? I think this is a huge problem with Cauda equina.
No, that's very relevant question. We document at every step. So our on-call referral is now all electronic. So the referring hospital, what they have found, what they've examined, and what we have advised, all these are electronically documented. When they come, initial admission by SHO and registrar will be documented. And I make a point, every patient with cauda equina, I see them before they go to theater. So I see them and that will be documented again. Now, if the patient lies or something is different, then obviously documentation becomes important. And in the long run, the documentation is always supported adequately. In my practice, whenever I had to go to court to give evidence. So documentation at every step, I would say, is very, very important. And in terms of catheter, I haven't gone into details about that GERFT pathway. Now, any cauda equina with sphincter problem, as soon as they arrive, they will get catheterized first before surgery. So they will be fully awake and get catheterized.
Yeah. So one of the things which I have noticed is that when you operate on many of these chronic lumbar canal stenosis, and as you know, in the UK, patients probably get delayed because of your waiting lists and, at the general practice level as well, where things are not picked up. At our level, patients have surgery delayed because patients want to refuse surgery. So what happens is we often operate on lumbar canal stenosis and post-operatively the catheter doesn't come out. And over these 20 years, I've realized that many of them would actually have a bladder dysfunction pre-operative. And so just to share with you, I do a post-void residue urine for all of my patients of lumbar canal stenosis, because this is something which you need to document. Now, you can't possibly do a urodynamics on all, because urodynamic is a little, scary and an invasive procedure. But at least a post-void residue is what I do for the lumbar canal stenosis patients. And then often we prove to them that you already have bladder dysfunction. Especially in the males, of course, in the females. In the males, of course, it can be because of the prostate, but in females especially. And it's actually the females who has the problem. So that's one thing. Satyan, you wanted to say something? You had raised your hand.
And Rajat,
Yeah, it was just before you asked about the consent. Wanted to check with Dr. Ghosh over here. We have, we often take a video consent from these patients, telling that we have explained that this is the problem and do you understand that this may not recover, etc., etc. Is there any such trend in your case? Because they just don't remember, or many times another relative pops up after a couple of months who has never been explained to about these problems before. So yeah, about video consent.
No, we don't do in our practice yet. But the consenting, what we do is documented and patient gets a copy after patient signs the form. So it's recorded, whatever we told, and it's also recorded in the patient's notes.
So Satyan, I just want to inform you that now in India, video consents are not going to be valid anymore. And this may shock you, because we always thought video consent is the best protection. But video consent is not valid anymore because of AI and deepfake videos. So, again.
Yeah, I understand what you're saying, but
I tell you what I do. What I do is that for patients of cauda equina syndrome or any neurological, whether it's a foot drop or paralysis or high risk, I get the patient's consent in their handwriting. So I get the patient to write that I understand that my bladder is not functioning, I'm doing the surgery and I don't know it will recover. So if a copy of this is in the notes and the patient comes to you after 2 years, what I literally do is I turn around the file and hand it to him and tell him, what is this written? Can you just read this out? Is this your handwriting? And when he reads it, he gets sheepish and he says, oh yes, sorry, doctor, you're right. It was before the operation. Because like I said, it's loss of memory, or they genuinely start believing that this was caused by the surgery, because patients are ready to believe anything. And of course, having a bladder loss, we should have some empathy. I think it's terrible for a young patient to have a bladder loss where he's on continuous catheterization or on an indwelling catheter. So, it's very socially embarrassing and distressing, but we protect ourselves as well. Rajat, you and then Agnivesh wanted to say something before we move on. Agnivesh, you? Rajat, yeah.
I won't take much time. I dictate my letters in front of the patients, and I think the consent is not one process. For me, consent is through various stages. Obviously, in cauda equina, it has to be done in one stage. Documentation is key, and at least in the hospital, I know how things work in India, in the sense that patients may go to various places, but they don't have the documents from each place. But here, the documentation is most places are electronic, some places are still doing paper-based. But there was currently recently a case where the judge threw the case out because the registrar documented very clearly his examination with the neurotips, his dermatomal examination, his myotomal examination, and everything was so clear that the judge was very impressed and said, everything was clear. When the patient presented, they didn't have cauda equina, they developed after. But I think giving copy of the records to the patients are probably useful.
Fine. So just
Samir, just to add on, Samir, sorry, just to add on that, I give a copy of the consent, and in my letter I dictate that I have given a copy of the consent and I'm sending this letter to the patient so that he can reflect on that. And if any query or clarification needed, she need to come back to us before surgery.
Okay, that's great. So there's a show of hands. How many of you feel bladders recover after surgery? Recover, hands up. Yeah. I'm usually skeptical about the bladder recovering. My God, that's a nightmare. So yes,
I think if the bladder goes and becomes complete, then it does not recover.
Yeah.
If it is incomplete, then you can still recover. Yeah.
The painless retention guys, they don't recover. Anyway, so we'll now move on quickly to the next topic, for which
sorry, sir. Yeah. Sir, there was a YouTube question. I'm just rephrasing it. So there are a lot of these papers about the timing of surgery. There is 24 hours, 48 hours, 72 hours, more than 7 days and all. So the YouTube question is that less than 72 hours, in the experience of the surgeon who has written the question, he feels that it's same. So he's asking, what is your experience about less than 72 hours and more than 72 hours after the surgery?
I think experience.
Can I just bring?
There's not so much data, but if you look at, in the UK, luckily there is one advantage compared to us, is that they have a little uniformity. So if there are already guidelines, like suppose Kaushik has a guideline which says 48 hours, then that guideline will protect at least the surgeon for 48 hours. There are some papers which do say 6 hours and 8 hours, and there are those which even say 72 hours and some which say 7 weeks. But of course, to my mind, it is do it the same day, and medico-legally it is 48 hours today.
Jayesh, you had a comment on it?
Yeah, two comments on this. One question to Kaushik and the other a comment on just the question that Agnivesh just put up. So there was a good paper from Nottingham, and this 24 hours, 48 hours, etc., I think is driven by lawyers, because it has been well established that the timing doesn't really matter. And this paper from Nottingham that Mike Grevitt wrote actually revealed that there was enough recovery after 48 hours as it was within the first 24 hours. So if you're looking at a very critical time factor, it has to be, as you said, within 6 hours, which no one can get to in their presentation. So the timing bit is driven by lawyers rather than true anatomical and statistical information. The other thing that I had was the question for Kaushik. Kaushik, in these bladder scans, because we in UK have a electronic referral pattern for emergency. So when you are on call, you get a referral from a peripheral hospital saying this patient is in cauda. And the classic question that is asked to these people is, what is their bladder volume? Do you have a critical bladder volume above which you get excited, or is it another figment of people's imagination?
See, Jayesh, that's what we looked into our study with those 420 patients. We normally, if it is above 100, we become a little bit alert. Below 100 residual, feel if there is no other major symptoms or red flag signs, then you can wait for a scan till next day morning. So 100 was our target number. But looking at our study, that I cannot see there is much evidence on that 100 number at all, because the mean was above 178 and 122. So I don't know how much it actually critically helps.
So fine. So there are some things which are going to be unanswered questions, but we have to do the best which we can. And I call on the next speaker, who's Rajat, to speak on post-operative. So we are already done with the beginning part now. Now we are going to what happens following surgery. And Rajat is going to speak about post-op discitis, and Agnivesh is going to be the rapporteur for this one.
Thank you. I'm going to try and keep to time, Samir, but obviously, if I'm going too far over, can you please stop me?
Okay.
Postoperative discitis is quite a challenge because as a surgeon, you may feel that, oh, I'm a failure because I've operated on this guy and this chap has become infected. Start off with sharing this patient of mine who was 72 when he presented to me in 2018 with this MRI scan, which shows the L3-4 disc central, but more little bit more on the left, and he had left thigh and leg pain. Did a standard micro discectomy. He got better, and about 4 or 5 weeks later, he went abroad, and while doing something, he developed again recurrent pain. So while he was abroad, he was given oral steroids and he was given epidural steroid injection. And then he represented to me end of March 2018 with this MRI scan, which was reported as showing compression of the cauda equina roots, which is not inaccurate. Thankfully, he did not have cauda equina syndrome. All he had was recurrence of his thigh pain, but I didn't really want to wait too long looking at the MRI scan, so he ended up having a revision. Following the revision, he developed severe abdominal pain and diarrhea on the first post-operative day. He had food brought in from outside, and retrospectively we thought that this may be a contributor. And he had high fever, rigors. Within a day or two, because he was having quite high fever, they took a blood culture while he was in the hospital. It grew E. coli, which is a bit unusual. But in any event, that's what it grew. His back pain was very classical. Discitis back pain is probably a 10 out of 10 on a visual analog scale. CRP was rising somewhere along the way. It was 174. I think it did go up to about 200. His white cell count was raised. So this was his MRI scan, and on the stir sequence, it was reported as showing features consistent with this discitis. And we put him on, after discussion with antibiotics, we put him on antibiotics intravenous. I use a PICC line, so I get one of our anesthetic colleagues to put in a PICC line and use that to deliver the antibiotics. I provided him with a brace, as you can see on the X-ray. Just as a kind of pain management measure, because he was just really struggling with pain. There was some improvement. There was some improvement in his symptoms. So why does it matter? So although it is rare, we don't see it that often, thankfully. But when it does happen, it is a very high impact complication, because you have a patient who comes in for an elective procedure who's otherwise well, and then he develops quite severe infection, and this infection can make patients quite unwell, and it can lead to quite a long, prolonged treatment. So antibiotic treatment for up to 6 weeks, 12 weeks. They may need resurgery, they may need biopsies, they may develop deformity if there is late recognition. So early recognition is essential. There are some risk factors, and this gentleman did have some risk factors, particularly revision. He also had the steroid injection fairly adjacent to the surgery. In my practice, I try and avoid surgery for 3 months after a epidural steroid injection. You may not be able to if the patient presents very emergently with severe symptoms, but I try and avoid an elective procedure within 3 months, really, essentially. Because in the literature, this is considered to be a risk. The concerns really are that, localized immunosuppression, you may inoculate infection in the epidural space. You may have, normally if you have discectomy, then the risk of infection is less than 1%. But if you have discectomies less than 30 days after an epidural steroid, then the risk is 2 to 3 times higher. By about 3 months, it starts to reduce. So, like I said, clinical presentation for discitis is quite classical. Once you've seen a post-op discitis soon after a discectomy, you rarely forget it because it is an extremely painful condition. Uh, if you stand in the room and just knock their bed while they're in it, they just hit the ceiling because the pain is so severe. Fever is generally a presentation, but sometimes fever may be absent, but there may be a lot of pain or back pain, and the CRP starts to rise fairly early after surgery. So these are generally the investigations that are considered. I prefer to follow CRP. You can do bloods and the cultures before starting antibiotics, MRI scan with stir sequences. Gadolinium, in our institution, we don't routinely do it. I know from our discussion on Thursday that Mr. Trivedi and Mr. Ghosh would prefer to proceed with gadolinium. So yeah, the gadolinium can be helpful, but our radiology team feel that whatever information we need, they can provide with a stir, and we use gadolinium sparingly. I do CT scans, not immediately, but if things are not settling in about 3 or 4 weeks of antibiotics, then I would do a CT scan to look for extent of bony destruction. And generally, microbiology team is very closely involved with treating these patients because they arrange the home IV therapy because our patients come into the hospital. They get the PICC line placed in, and then they get sent out in the community, and the nurse goes and gives them antibiotics. So that's a funded system that works. Very occasionally CT guided aspiration, but that's not that common in my practice. I mean, mostly with the help of microbiology, we can get on top of the infection. It would be nice to have a bug and a culture before antibiotics are given, but generally after blood cultures are taken, then we start on our best guess antibiotics. If the patient is stable, then targeted IV antibiotics. If the patient has got evolving neurology, has got a large abscess, then you may need to go in and debride and stabilize. So this is what I generally do. I find CRP and clinical improvement the most reliable way of keeping an eye on things. I avoid doing routine MRI scans early because MRI generally lags behind clinical improvement. So we can get this disc and end plate erosion collapse, which is what this patient developed in May 2018. After telling you not to do early MRI, I did do an MRI, but the reason I did MRI was the patient was not improving as I wanted to from the back pain point of view. And following this MRI scan, I got a CT scan done, which shows quite extensive destruction. And in my experience, gram-negative infections seem to cause more bony destruction. So if you do have a E. coli, then you have to be more alert to bony destruction. He started developing sagittal imbalance. So if you look at these two X-rays, in this X-ray, his head position is such that he's leaning forward. Here he's more upright. So there's progression from April to May. I took the decision quite early to stabilize him. His CRP had started to improve with the antibiotics. It was not quite normal, but I thought it would be safer to stabilize him before he develops established kyphosis. This was him post-op after instrumentation. So you can see that his sagittal posture has improved I know in this image, I've not got the head, but it was getting quite difficult to get him to stand up long enough to get a proper X-ray. But the AP X-ray gives you an idea where his head position is, because after the instrumentation, his head position is a lot better. I did protect it for a while with like a 3-point brace, cash type extension brace. So this was his imaging in June 2018. You can see that there is some improvement in the bone destruction there. His MRI scan. Then this was in December 2018. So he's a golfer. He plays a golf at my club. And it was extremely important for me to get him back playing golf because he is a very, very keen golfer. And I did get him playing in December 2018. He was back to playing golf. This was him latest scan. He came to see me for back pain. I think his L5S1 is going, but this was just the September 2024 scan. So take-home messages generally are after surgery. If you have significantly worsening pain and rising CRP, then you have to suspect discitis. Culture before antibiotics, if possible. MRI, I think, is the key for diagnosis and discussion with an experienced radiologist. And have an algorithmic management. So wherever you're working, take help from the microbiology team because they will know the type of organisms that are there in the community and they will help you give the best appropriate antibiotics and stabilize early. If you see bony destruction and kyphosis, stabilize early. You won't regret it. Again, just a plug for our meeting coming up in Aberdeen, 29th April to 1st of May. All are welcome. Please register. The emails are here for you to look at the website and also email info@spinesurgeons.ac.uk. Thank you.
Yeah, great talk. And you did stick to time, though overall we're running a little late. Agnivesh, you are the rapporteur for this.
Yeah. So, Rajat sir, I want to ask a question. Is that do all of these discitis patients, they develop symptoms immediately or there is a timeline, for some time they are well and then they start coming back to you with symptoms? And when is the time when you should suspect this, that the patient is developing a post-op discitis?
I think broadly there are two groups. One is the very early acute patients who you will see more or less immediately. Within a day or 2, 3, maybe 5 days, you'll see that they are becoming unwell. The second is the ones that grumble along. You'll see them in clinics. A few weeks later, they start developing pain and discomfort. So you can have two groups of patients, and it's not necessarily very early. This particular case presented very early. He was an inpatient when he developed this. So yes, there are two groups. What was the second part of the question, Agnivesh?
When do you start suspecting that, oh, this is the patient who is developing a discitis?
So the ones that are not settling down with pain and the CRP is rising, then you start suspecting that there is something going wrong. And if patient with pain after discitis and which is not settling, mainly back pain and CRP that is rising, I will get an MRI scan.
And is there a role of conservative management in this post-op?
Oh, yeah, absolutely. I mean, not everybody who ends up requiring surgery or washout. A lot of them can be treated with intravenous antibiotics for 6 weeks or 12 weeks, whatever your discussion with the microbiologist is. The ones that requires that, I think, stabilization are where they start developing extensive destruction of the bone.
Okay. Mir sir, any questions, comments from your side, and then we move on to Dr. Satya?
No, I think the dilemma is when to discontinue a conservative line of treatment because the patient is really in bad pain, and when do you really want to intervene? One, if you don't have a frank osteomyelitis setting in, that dilemma holds because the response to antibiotics is what you are monitoring with your serial CRPs. So the patient often remains in pain for 1.5 to 3 months before you really decide to intervene in these patients. And really an intervention really solves the problem for them. So that dilemma would always remain.
Right. Dr. Satyan?
Yeah, my question to Dr. Verma would be, how aggressive are you in offering fusions to these patients? Because as Mir said, they are in tremendous amount of pain and it goes on. The conservative management takes quite a long time for them to settle. Do you, what are your protocols to fusing them?
So in my mind, I try and simplify the solution, the problem into two broad categories. One is the infection, and the second one is at some stage it becomes a deformity problem. So if I can treat the infection without developing a deformity problem, then I don't need to stabilize. If I have treated the infection, but then gradually it is becoming a deformity problem, then I will intervene and stabilize early. When I mean deformity problem, generally it is sagittal plane problem. So patients start going into kyphosis.
Would you fuse them for pain alone?
Yes, yeah, they're in severe pain. They become it's a very mechanical type of pain where they have a lot of pain every time they try and move. They're in a lot of pain. So that's when I would intervene.
And so how long would you wait for the IV antibiotics to work before you say, okay, now it's not working well enough and we should fuse them?
So in our protocol, we do when the CRP is high, we do twice weekly CRP with the antibiotics on. I expect to start seeing CRP coming down within the first week. Don't come down to normal. You see a trend graph going down. Once the CRP is normalized, I do it once a week, and then at 6 weeks, if we intend to stop the antibiotics, then we stop the antibiotics, and I do it for further weekly CRP for another 2 or 3 weeks to make sure it's not rising back again.
No, I mean, in your protocol, is there a patient's pain score that, okay, now if the pain is this much and it's not improving by 3 weeks or whatever, then you may offer a fusion? Or is it only
Like I said, a
based
fusion
on...
is offered if you suspect the patient has got osteomyelitis and developing kyphosis. You may do a CT scan. You
But
may
not
do
for pain alone.
if there's no bone destruction, then I wouldn't necessarily fuse the patient. No.
Right. So
Okay,
in interest of
I think we are in the interest of time, we need to move on, and we are really already like 20 minutes over time. Now, one of the problems of having a celebrity surgeon like Mihir is that he's committed elsewhere. So he's requested to jump the queue, and I'm going to ask Mihir to come next. So unfortunately, late recurrence is coming after Satyan's talk, which is early problems. But Mihir, please take over.
Yeah. So, guys, I'm not going to give a lecture here because late recurrence is like a fresh disc herniation which comes after 3, 6, 1 year, 2 years after the primary surgery. So I'm going to throw open these discussions because Samir wanted me to present something really odd. So I'm going to start presenting these cases to you, and please, all of you, volunteer your opinions on them. Am I audible?
Yeah, we can hear you.
So this is a 74-year-old doctor with right leg pain and SLR of 30 degrees, an acute onset of right foot drop, a painful one, Samir, for last 2 to 3 days with a motor power which was non-functional. Sorry. Yeah. So this patient had undergone a transforaminal endoscopic discectomy on the right side for the same right leg pain many years back. Now, this was the MRI that the patient presented with. So there was a MRI which showed probably a left disc extrusion, and there was a predominant weakness on the right side. So what do you guys feel about this?
And his pain was on which side?
The pain and weakness was on the right side.
Okay, symptom was on the right. Okay.
The symptom was on the right. This is the patient walking with a foot drop.
Oh, yeah.
And this is his weakness on the right side.
Can we go back to the image?
You want the image here? Yeah. So
I know, but the thing is that the side is a bit odd, but at the same time, you can't ignore that disc and you can't ignore the finding. And if the pain, and if it's with pain, so it's definitely a radiculopathy. So I think to quote a saying, if it looks like a duck and if it quacks like a duck, then it's a duck. So we can't leave this alone.
So, guys, please notice this arrow here. Can you see this?
Yeah.
So now the interesting part is that this looked posterior. The disc here looked anterior. So
I mean, we are seeing only one cut.
Yeah, is there a cyst? Has he got a ligamentum
Like a
cyst?
ligamentum flavum cyst. Yeah.
no, actually, now let me come to the fact of this is we thought that it was a posteriorly migrated, disc fragment, and this is what showed up on a contrast MRI. The disc is actually on the right side, and the caudal sac, what looks like the disc, is pushed to the left anterolateral side. So actually, this patient had a matching deficit on the right side with a posterior migrated disc herniated on the right side. So this was a little atypical presentation. And this is what it looked when we excised it. So it was actually a cuff of disc tissue, like a spinal tumor syndrome on the right side. So this is a recurrent disc, which was with a clinico-radiological mismatch, it appeared to be. But the MRI, when done with a contrast, showed the actual disc fragment. So this is the first scenario. Now this is case number 2, a 60-year-old.
Just a comment, Mihir.
Yes.
Sorry, I put my hand up. I mean, it's interesting, this one, what you shown the last image, but I have seen quite a good number of patients where the side doesn't match accurately, but there is mild compression even on that side, more compression on the wrong side. Initially, I used to have a dilemma, but now with operating few of them, I decompress both sides and they do get better.
Perfect. So that's usually our understanding too. That means you can have a contralateral symptom and you end up decompressing them and hopefully they get better, because you can have a persistent leg pain. That's the next talk. So the case number 2 is a 60-year-old chartered account by profession, left anterior thigh spasms, of a femoral stretch test, which was positive, neurology was normal, morbidly obese with diabetes. Now, this patient had undergone an L3 to L5 fusion prior to getting a disc herniation at the L2-3 level. The disc herniation was treated with a left microfenestration, and the patient went home quite happy, relieved of symptoms. In 2021, again, the patient presented with right anterior thigh spasms on the opposite side and a subjective weakness of the quadriceps with pain. So now he had developed a disc herniation on the right side at L2-3 level. So there is a fusion below. There is an intervening L3-4 segment, which is normal. There is a recurrent disc on the opposite side at L2-3. What would the panel do? Again, a discectomy, a floating fusion, a dynamic fusion.
I'll go for a microdiscectomy on the right side.
So does everyone agree?
Yeah, I think I would also do the same. But what you have about flexion extension X-ray, right?
Yes, we have a flexion extension X-ray. It's a stable segment. The only thing is that it's a very narrow canal and it's already been operated. And this disc is more or less central to paracentral. You can see the facets almost kissing in the midline. So of course you can tackle it. There's no problem. But this guy has had a recurrence already.
But this is a virgin level, isn't it?
No, this is the same level which was
But
operated.
this is a virgin side.
Virgin side.
Yeah. So I will still
So
do a
this-
microdiscectomy.
This was the left-sided disc which was operated at the same level. And now it is a right-sided disc at the same level.
Okay. I missed that. I didn't realize. Sorry. Okay. I still think because, one can give it another shot with another discectomy because if you have to fuse it, then you have to fuse it all the way up. Then you're fusing another unnecessary disc in the middle.
So
Yeah.
what is your thought of a floating fusion?
No, I would not do it. He will definitely land up with with that level in some time.
So
I think I think it's reasonable because considering decompressing at L12 level is not straightforward. The thecal sac is full, and you may struggle sometimes without. You may end up taking quite a lot of facet. Looking at his facets a little bit more sagittally oriented than I would like. So yes, floating fusion is possible, but then obviously patient is going to so it's possible. That's not the reason.
So luckily this patient has withstood about 6 years. We are just waiting for the L34 to break down in the future. So this is a third case, a 23-year-old cabin crew with a disabling right leg pain, duration of 3 months, SLR at around 30 degrees, neurology is normal. So you have a sort of a partially calcified disc with an extruded disc with a degenerative protrusion at alpha S1. Now this patient underwent a microdiscectomy and went home happy, and a few years later developed axial and right anterior thigh spasms again. The right SLR was positive, neurology normal, comorbidities are nil. So this patient had a recurrence of the disc previously operated as well as a little increase in the L5-S1 protrusion as well. So now what would the panel prefer? Is it 2 microdiscectomies or 2-level fusions?
I'll discuss both options with the patient and throw both of them to the patient.
I think the L5-S1 compression of the root is not that severe. I know it's a central disc, but I don't think the root is getting, S1 is not getting compressed significantly. The L4-5 certainly is a lot worse.
So, Rajat, would you fuse only the L4-5 and leave your L5-S1, or you would fuse both?
If it is the first recurrence, if it is a first time recurrence, I would just do again a similar decompression. And I generally tend not to fuse at the first recurrence.
Any other thoughts on this? Because Samir has already said, I love to fuse. So the answer is pretty clear for me.
So Mihir, I'm dictated by a lot by the patient's symptoms and past history. How intense is her back pain as well? Because your fusion is in an attempt to try and treat the back pain, perhaps stop further recurrences. If your primary aim is to help the back pain as well, then perhaps fusion may be indicated. But if it's predominantly leg symptoms that she's come to you with, I would, like Rajat, do a discectomy. I follow the baseball rule, 3 recurrences and then I fuse. So 3 strikes and a fuse. But I would be dictated by the patient's symptoms. If she's not got significant back pain, I would still err on the side of a discectomy.
Unfortunately, what happens is, now this lady was a working cabin crew and she was functioning till the time she gets her recurrences. Now the thing is, when you have a recurrence, there's always a lot of spasm. So the back pain is always very, very significant at that period in time. And it's really difficult to judge, for you to judge whether the back pain is significant or not. The patient always says that I have back pain.
Or whether the back pain is coming from a 4-5 or 5-1.
Exactly. So that dilemma is always going to be there. So as a surgeon, I think the decision is only between a discectomy. Now, the problem with Indian patients is that they pay for their surgeries. So, so the thing is, they want something very definitive and don't want a recurrence. Obviously, patients all over the world would want the same. So, for recurrences, usually I tend to err on the level of fusion. So, this patient underwent a fusion. So far, she's doing well. Now let's wait for the adjacent segment to break down. So case number 4, my last one, a 68-year-old housewife, right leg spasm for about 10 weeks. Comorbidities, hypertension, diabetes, past surgery, L4-5 discectomy. So this is a microfenestration surgery in the past, and there's a big recurrence with a tall L4-5 disc and quite narrow canal with encroaching facets. So would you guys do a discectomy again, or would you fuse? Now, if you see the X-ray, the pars looks very, very thin of the previous microsurgery.
The way you're presenting it to us, you're setting it up for a fusion, because
No, no,
I'm just saying, one second. Because you are saying, oh, it's a tall disc, the canal is very narrow and the pars is very thin. Now, anybody who use this,
if I'm worried about the pars, I would get a CT scan, because I've got several patients who have had decompression, who have had a iatrogenic pars injury. And if the patient has got a pars injury or a pars fracture, then I would fuse the patient. If they don't have it, then I would probably do a decompression.
So my concerns are exactly this. My way of pointing it out was, if you try to do a recurrent discectomies with such a thinned out pars and you end up having a facet injury, I think, would you be prepared to have a fusion available on table? So would that be a part of the plan, or would you go ahead just thinking of a discectomy?
No, I think
I would do a CT scan.
In this case, you can go either way. I think you need to discuss with the patient. I think the issue is as to whether the patient agrees that the patient may need a fusion in the future. And let us say we put it at 50-50 that she needs a fusion. Then if we do a fusion now, then that's it. It's all done and finished with. But then, of course, then there can be adjacent level. So basically, you are having a toss up between an adjacent level versus a same level recurrence. And sometimes you need to little involve the patient in that decision making, because you can do either. It's like, of course, everyone can do a fusion. So doing a fusion is not a problem, but you can also get away with doing a discectomy if this patient mainly has leg pain. And I'm not a great believer in back pain as a spine surgeon, saying that you may get shocked. But I'm not a great believer in saying that fusion looks after back pain, which again makes me a bit of an outlier. But I say that I'm more confident to treat leg pain. So if this patient has mainly leg pain and this patient is okay for having a fusion at another time if necessary, then we can definitely just do a discectomy. And I don't think that thin pars or anything is a problem. If she's not unstable, one can definitely dissect and get this fragment out slowly but surely and decompress the nerve.
I think in my books, a unilateral pars defect does not contribute to any kind of instability. The opposite pars is okay. I mean, so many times you may have had patients having a unilateral pars defect and all. They go through life quite merrily. I think unilateral pars, it's a myth. It lowers your threshold for fusions. And let us not forget that fusions come with their own baggage. I mean, Mihir is a very skilled surgeon, but if we kind of end up doing fusions for recurrences just because the pars is thin on that side, I think we have extended the indication for fusion significantly.
So I think that's a very good take-home message, is that you can keep doing micro discectomies 1, 2, 3 times before you really arrive at the decision of fusion. Like I said, my thresholds are less because the patients demand a little more and they are a little frustrated with the recurrence. So you can always counsel them otherwise, but my threshold is to fuse. So now this patient, after 15 months of surgery, had a third recurrence.
Oh, okay. So a fusion wasn't done, is it?
Now wasn't done.
Okay.
So now the patient had a recurrence again. So now what would be the choice?
I mean, it depends. If this is symptomatic, then
It's
now,
very symptomatic.
so
Disabling, absolutely.
Jayesh said, it's 3 strikes and you're out. So that's a 3rd strike. And in this case,
Headbound status.
the disc is more diffuse. It is, even the foramen, if you look below the facet on the right side, that is also full. So I don't think you can get away without a fusion in this case. I think here I would do a sort of MIS fusion for this.
So anyone for a transforaminal endoscopic decompression again?
No.
Not me for sure.
Yeah, no.
So ultimately she ended up having, so should I stop here because this can go on? I think I've run out of my time. Okay, so
Mihir, I'm going to quote you a little here for your last patient. You said something that is very practical in the Indian scenario. That patient will not accept a same level recurrence, but people will accept another level recurrence, or rather they will blame the surgeon if that's the same level is a problem. And so therefore in Mihir's book, if there is a toss up between fuse or not fuse, he prefers to fuse. And I don't know at this point, and this is not for you all, but it is for the juniors who are watching this. If any of you know the history of the pliff, the history of the pliff was because of Ralph Cloward. So Ralph Cloward was banned from the United States mainland because he was a spine surgeon. He had a lot of failures, and who doesn't? And he then started practicing in Hawaii. And then in Hawaii, it's a small community, so he didn't want to have any failures over there. And therefore, he started this process of doing pliff, where he said you cannot have a failure at the same level. So I think Ralph Cloward, and then after that we have Mihir.
I think just extending on what you said, Samir, you're right. And I think Mihir is also right. If you did your fellowship in Hong Kong, Hong Kong was the place where anterior surgery was propagated. Their standard treatment for acute disc herniations, not first, second recurrent, first disc herniation was an ALIF. Everybody got an anterior lumbar inter. Their rationale was very simple. We don't want to invade into the canal and get epidural fibrosis and recurrent leg symptoms. We don't want to get recurrent disc herniations. And they were so slick with their ALIFs that they could do an ALIF in the same time that most of us mere mortal surgeons take to do discectomy. I think the point here is patient selection is very important, number one. And number two, you have to be skillful. Mihir is very skillful in his MISs, and in his hands, a fusion works better than a discectomy in most average hands. So I think there is some theory behind that, but we need to kind of focus on the patient.
Yeah, Mihir, excellent show, lovely cases, and you really stuck to the case-based discussion mandate which was given.
I thought that is what you expected of me. So
I agree, but for each case is individual, and for discitis, it's like a common thing. So anyway, well done, Mihir. Thank you. We'll relieve you at this point. Reluctantly, we would love your inputs, but I know you have got another important pressing arrangement, so you can go. Thank you, Mihir. Thank you very much for being part of this.
Thank you. Bye, guys.
Call on Satyen now, who has also a very difficult and a tricky topic to deal with. Satyen, please share your screen and.
Yeah. So, can you see my presentation?
You can see it, but go to play, please.
Okay.
Yeah, that's it.
Yeah. So I'm talking about early recurrence or early, persistent radiculopathy after doing a lumbar discectomy. So this is again, I'm starting with some cases. This is a 39-year-old male who came with severe right low limb radiculopathy, and despite all the conservative management, he was not getting better. He did not have any neurological deficit, and this is what his MRI showed. So, in fact, I'd like to involve the panelist, Dr. Verma. So, what do you think about this case? Would you offer this patient straight away a micro discectomy or one-sided? What are your thoughts when you see this?
I mean, the foramen, I guess, is okay, and the patient has no deficit.
No, he doesn't have any deficit.
And it's mainly for sciatica.
Yes.
I must say I would initially try and see if I can relieve the sciatica with non-surgical measures.
Yeah, of course, that has been tried and he continues to have pain. So now we are discussing surgery for this patient.
Okay, if we are discussing surgery, then the next step, I would probably consider doing a microdiscectomy, right-sided.
Yeah,
In your list, you've got laminotomy. I would probably do. I generally tend to do a laminotomy.
yeah.
You,
You can notice I don't have a fusion in my list. I don't fuse any of these cases. In fact, I wanted to take your opinion that do you think the interpedicular space is narrower? Does he have
yeah, I
a
mean, looks
narrow?
looks narrower, but the other levels will give you an idea. But in spite of that, I would do it. But I think just my observation over the years for the viewers generally is that if you see a disc prolapse which is going straight back in the line of the disc space, technically it is a significantly more challenging procedure than a disc fragment that has come down and is lying behind the lower body, because
Mm,
this disc is probably lying behind where the nerve root comes out, where is lying behind the shoulder of the nerve root. So you have to
yeah.
just be careful when you see this type of image on the scans.
Yeah. I had actually, in this patient, discussed with the patient that I may have to take off a little bit of the midline as well because it looks very tight and also his canal is much narrower than what it should be. So when I opened this patient, I was not able to get a good retraction by doing just a laminotomy, and so I did do a midline decompression. I got a good amount of disc out, and the patient felt much better. He had a little bit mild pain, but not too much of pain. Normally, I attributed it to some residual radiculitis, and the patient was discharged the next day as normally they are. 3 days later, this patient calls up with again the same symptoms, right-sided, but they are now increased in intensity, but not as bad as what it was originally. So at this stage, what would you prefer in this patient? What would you tell him? Would you just counsel him, or would you think about giving him some steroids?
I wouldn't give steroids. I would try and reassure, and unless the patient has got a deficit or severe sciatica, I wouldn't necessarily repeat the MRI scan because it just causes a bit more confusion. I think
Yeah,
in my a
yeah,
very early post-operative MRI can kind of confuse the picture a little bit. So
yeah,
unless there is a really good reason why I'm scanning, the reason to for me, the reason to I would scan is if patients developed a deficit or the sciatic symptoms are so severe that they cannot manage. But
yeah.
I would give
And would
steroids.
any of the other panelists get an MRI done earlier?
No, I would do exactly what Rajat was saying. If only MRI, if there is deficit and the pain is actually worse than preoperative, what he had.
Yeah. And would you also just give him some reassurance and continue with
Reassurance,
analgesics at this stage?
yeah,
Yeah,
properly, optimize the pain management.
yeah.
So,
And that is what
I
I also did.
I
Yep. Yes.
I would like to differ from the panel thus far. So you said 2 or 3 days later, the pain has called up, patients called back with recurrence of symptoms. Uh, I would look at the trend because one of the things I agree with Rajat that you don't want to be doing an MRI too soon because it muddies the waters. But how do you rule out possible complications like a hematoma that is forming at that level? Because if your symptoms have been getting worse, then you are duty bound. Okay, there may not be any neurology, but there could be a hematoma that is developing that could then end up causing neurology. So I would tend to keep the MR scan option open, but I would see the patient more regularly and see how his symptoms are developing.
Yeah. Thank you, Dr. Trivedi. I'll go ahead. In this
So
patient,
I just give me 1 minute for my 2 bits. So I think because pain is a subjective symptom, and a lot depends on the patient personality. And some or the other, we tend to know our patients, in a private practice, we don't have like hundreds and thousands of patients. We tend to have an impression of this patient's state of mind. So for me, if it's a sensible patient, like into inverted comma, sensible patient who is complaining, I'll have a chat with him. And if he really feels, okay, there's pain and there's SLR restriction, etc., then I would take it a hell lot more seriously. And there are some others who just complain about everything, the pain, blah, blah, blah. Sometimes there are even secondary gains. And, without, I'm not being sexist, but it's a true social fact that, women will do it for a little sympathy, or they just think. So I will try to get a grip of the patient personality as well, and I will try to put that symptom in the in the shadow of looking in the light of what is the patient personality, which is my opinion.
Yeah. Basically, we have to see our own patients, and it has to be very subjective based on what the patient has. So this patient then continued to have increase in pain, and the patient came back with severe radicular pain and of the original intensity. So he still had normal neurology and required admission. So at this stage, I think I went ahead and got an MRI done, and this is what the MRI showed. So if you can see, we'll go back to Dr. Trivedi. Dr. Trivedi, what do you think about this MRI right now? You've seen we've taken off a little bit of the midline and got a good amount of decompression, especially on the right side.
Yeah, so this is something I would like to discuss with my radiologist, because the initial impression is that there is a residual disc on the left side, which is there. And I know that his symptoms were not on that side. But here I would like to make sure that the radiologist or someone competent enough tells me there is nothing else, there is no hematoma, there is nothing else brewing, because that is what is important.
Yeah. And there was nothing else going on. It was just another extruded fragment on the left side. Is this a new fragment, or is it something which has been missed out from the previous surgery? Is there any way to know that, or just to be
comparing with the previous scan with the radiologist? Sorry, I was going to make a comment differently because of Jayesh, what he said. Important is to look at the trend. If the patient is really complaining of worsening symptom, I'll see them personally. Follow-up here, it takes a bit of time, routine follow-up. It's not like a private practice in NHS. If the patient develops neurology, then definitely a repeat MR. But the big problem of MR is interpreting the MR post-op situation. It becomes really difficult in first 2 weeks. Even the very experienced neuroradiologist, we found it's not always very helpful. And in all of our practice, I'm sure we see that these patients, lot of time, first few days complaining of pain, we say, okay, reassure some painkiller. In 2 to 3 weeks, they usually get better.
That's right. So what about this case now, Dr. Ghosh?
I mean, I wouldn't do it. It's on the wrong side. Much better looking than pre-op. I know the pain. I will just hold on if the patient doesn't have any neurology.
So just reassurance and continue with analgesics.
Yeah.
Anybody differs on this?
I wouldn't rush into surgery if the patient understands what's going on. Definitely won't rush into.
Yeah. So I did the same thing. I was just talking to the patient. I counseled the patient that this should get better because there's a good amount of decompression done, and if there is a little bit of fragment, it should get resolved. But the patient then was not able to bear it. He said, "No, just do something and get this done with, please." So if this is the case, then what do you then offer to the patient? Would you still say, okay, maybe we'll try a block, or would you say, no, we'll go and do a discectomy?
No. I mean, if you are going to do any intervention, I wouldn't do block in initial post-op period. I would go for revision discectomy.
Yeah. Dr. Dalvie, would you want to fuse this patient? Mehir is not there.
I don't think I would fuse. I would just do a re-exploration and just see that the root is okay, whether any fragment is there. And you will find a fragment. If there is pain, there'll be some kind of fragment or something which is irritating the nerve.
Yeah, yeah.
But
So I did.
so the thing is that there is always a tendency that you want to postpone it. But the only thing is that doing it in the first 4-5 days is just opening the stitches and putting a retractor, as opposed to having to redo the whole exposure and everything.
Yeah. So this was actually redone in about 10 to 12 days after the surgery. And I just had to open it up, and we got again a lot of disc fragment out again. In fact, the entire disc space looked like it was empty then. But it did not fuse this patient, and he did quite well after the procedure, and he's been asymptomatic ever since. I'll go on to another case.
Sometimes, what happens is, Satyen, that the MRI. So I think for me, MRI is just a aid, and my decision making is always on clinical grounds. If you see my surgery, any spine surgery I do is only based on clinical indications. So if he has pain, and even if the MRI looks like this, I would still go. And I think what happens is that you must understand that the MRI is done in the supine. So sometimes when they sit or stand with the pressure, there is a further protrusion and extrusion which you can't see on these scans. So if clinically there is an increasing pain which is very concordant, SLR is restricted, and the patient is sensible, then I would just go down and have a look, and I will be surprised because an MRI isn't as opposed to an MRI which is bad and the patient is okay. Again, I wouldn't touch that patient.
Yeah, obviously. Yeah.
Clinical grounds for me is the most important indicator for any kind of intervention in almost any aspect of spine surgery.
Yeah, thank you for that. So I'll go on to the next case. Your comments on this one. Then this is a 54-year-old male who was a diabetic, and he came with severe left L5 radiculopathy and not responding to conservative management. I'll show you the axials. This is what the axials look like, and there's a little bit of compression on the myelogram. How enthusiastic are you about doing a discectomy in this patient?
You tried non-surgical treatment first?
Yeah. It's been going on since couple of months, and he continues to have pain.
Yeah, I'll go for a discectomy. I'll just share an experience. Was a ophthalmology consultant in our same hospital. Very similar looking scan what you are showing. In fact, slightly less compression than the scan you are showing. I tried for 2-3 months. There was no improvement. And then ultimately I landed up doing a discectomy, and she's completely pain-free.
Yeah.
In this axial image, it appears to me that the facet has got a little bit more fluid than I generally like.
Yeah,
I think it would be useful to get a standing X-ray to
Yes,
see.
yes. It was done, and there was no instability. So we routinely get those done in our patients. But Dr. Verma, what is your opinion on diabetic radiculitis versus this kind of a disc compression? I mean, does that confuse the clinical picture?
I mean, just looking at this, I'm not sure I would necessarily offer a discectomy. I would probably just continue with epidural steroid injections. If the epidural steroid injection is not having any effect, then I would be very wary of doing a discectomy, because epidural steroid, you would expect it to work. Even if it doesn't work for a long time, you would expect some improvement. You use it as a diagnostic and a therapeutic injection. Not sure about diabetic radiculitis. I think you can get it, but not something that I would be. That's probably I'll have to get a neurologist, etc., to see and then decide, what we are dealing with.
Anybody else would want to jump in before I go ahead?
No, go ahead. It's nearly 11.
It's late. So this patient underwent microlumbar discectomy. He had some partial relief in symptoms post-operatively. And then he came back again in 5 days with some more pain. It was not very bad, but he still kept on coming with grumbling pain. So I asked him to get another MRI done at this stage. And this is what the MRI showed. This is the axial picture here. Dr. Dalvie, your views on this?
This patient has right-sided pain?
No, left-sided.
Left-sided pain. Oh, okay.
So he had some on the MRI. There was some right-sided compression as well. So we did a decompression there, prophylactically, if you want to call it.
Yeah, but I mean, a lot would depend on how much pain this patient has.
No, it's just grumbling pain. It's not very bad, but it is there. bad enough for him to come to us?
I would wait. I mean, if the patient is, if there's no severe acute pain, then I would wait, because there is some, there is some soft tissue there, post-operative sort of tissue is there, and scar tissue is there, and then whatever little bulge is there, that will settle down by itself as well. So there must be a compromise. One is not denying that, but it will settle down. I mean, I would not at this stage, unless it worsens. I would not jump in at this stage.
Yeah. I agree with you. That's what I would also do. Just treat them conservatively if it's not very bad. Anybody wants to jump in with their opinion here?
My query to you is why you are thinking of diabetic radiculitis rather than the disc pathology, which is still there is some irritation. I agree that we wouldn't jump for another operation, but for all practical purpose, I think it is still coming from the local compressive pathology.
Yeah, Dr. Gush, in my experience, I've seen a lot of patients who come with very mild or no neural compression on the MRI and who are diabetics. And if their sugar especially are fluctuating, even if it sometimes just increases too fast or it is coming down too fast, they get a lot of radiculitis, and they complain of these typical pains, which normally we would think of as an L5 or an S1 radiculopathy. And on the MRI, they have hardly anything. And that's the thing where it becomes very difficult to differentiate between, a diabetic radiculitis versus a surgical case.
I fully agree with you, but in this particular case, we can see there is some compressive element since beginning. So I would be still more in favor of compressive pathology rather than diabetic radiculitis.
Yeah. What I'm trying to say is that many of these patients have got superadded diabetic radiculitis as well. And so they do continue to have a little bit of pain even after the decompression is done.
Could be.
So,
but in my experience, they usually get bilateral symptom.
The other thing is the symptom, the diabetic, the problem is the tingling, the pins and needles and the numbness, which persists for much longer rather than pain. I think that's one that doesn't get better in the diabetics, and they keep cribbing about that.
Yeah. So, I just wanted to make a few points here that lumbar discectomy, although it gives you an excellent outcome in majority of patients, 10 to 30% patients do report with some recurrent leg pain or some persistent leg pain. And there are three broad categories of getting early recurrences, especially. The first one is a mechanical or surgical cause, where there may be a residual disc fragment or a recurrent disc herniation occurring at that level. Foraminal stenosis very often can get missed, as Dr. Dalvie had said. And also wrong level surgeries are a known cause of getting persistent leg pain post-operatively. These are your mechanical causes. In biological or healing causes, any nerve root injury or inflammation because of handling of these nerves can cause some amount of pain. If there is some hematoma and some inflammation, also can cause that kind of pain. And then the patient factors. In patient factors, as we discussed, diabetes, diabetic radiculitis can cause these kind of pains. Incorrect diagnosis. I've seen so many patients who've undergone discectomies who actually had other diagnoses like sacroiliitis, even stress fractures of neck or femur, but which was actually causing the pain. And a psychological overlay is something which is very important, and we should try as far as possible to rule that out, although it is very difficult to do that consistently. So in management strategy, most of them do not need surgery, and they get better with NSAIDs, neuropathic medications, steroids, etc. And sometimes you may need roadblocks, and rarely you may need to reoperate them. The key takeaways here are that persistent radiculopathy is not uncommon, and there is the risk of this. And I think it is very important to counsel these patients very well, because in the end, this is about treating the patient. It's not about treating the disc, but treating the patient over here. And so if you counsel them well, you often get good results. So I'll stop over here, sir. Thank you.
We have. I mean, with something like a disc, we can just go on forever. And it's been a most interesting, if you can unshare. It's been a most interesting session, actually. I think, I'm not sure whether all our 800 listeners have learned anything, but I think we all learned a lot from each other today. So I think that's been good. It falls on me to wrap this up because the secretary had to leave because he's starting at 6 a.m. tomorrow for, a foot and ankle session. So BOS has become extremely busy now. It's not a relaxed session anymore. And I think although our one of the achievements was to get all of us together and to share knowledge, and these videos will be watched again and again because our channel partner will make these into shorter videos and push them on the social media. So each topic, each separate lecture will also be sent again. And at this point, I have to thank. So this is telecast on two channels: the BOS channel and the Ortho TV channel. Ortho TV has become a very big sort of thing in India, where they have a lot of good programs and they have great viewership. So even students and people will log on to this and they will do a social media push. So you'll have a lot of people logging on to this and benefiting from this. And I need to thank also the financial sponsors, which is a pharmaceutical company called Torrent Pharma, because we do need some finances to support some of the events. And I have to thank BOS. I have to thank Gautam, who isn't here today. But the whole of the BOS who put this through, but I'm thanking myself as well because I'm the incoming president. And Jayesh, who's the executive committee member who's stuck here all this time. And for a non-spine surgeon to stick to 2 hours of spine surgery must have been quite a challenge.
It was very enlightening for me. I got to learn quite a lot today, actually.
So even if you learned, we have done our job, right?
Yes.
Anyway, so it is also, I must thank the Indian faculty because it is late. It's 11 o'clock. It's a Saturday evening and we get that. And I thank, of course, my British colleagues because to get a Britisher to work on a Saturday is not an easy task. Because I remember when I was there, all the conferences used to end on a Friday at 2 o'clock. And I used to say, what is this? Because our conferences start on Friday. So, to get you all to come on a Saturday has been great. You've sacrificed, obviously, your personal time and your family time, both in preparing and for joining this. And I really thank you. It's been superb to share this knowledge. And unless some of you want to say anything else, I will like to end this session.
No, I just say thank you very much for inviting us for BO from BAS. And I'd like to thank Rujuta as well. She helped coordinate quite a bit of it for us. I mean, I was constantly in touch with her. And hopefully we will be meeting soon in Aberdeen, all of you guys.
And Rujuta is also our common classmate. She's another link between the two of us. And she really used a stick and made us do stuff when it looked as if we were slowing down. But we were never slow. Spine surgeons always, we are always the winners. We always come and win. And I hope this encourages some people to go to the BAS meeting because I think it'll be a great exchange. And let's see if we can collaborate somewhere along that. So I thank everyone. And with that, I say adieu and good night and have a good weekend.
Thank you. Thanks very much, Samir.